Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as treasurer of the World Federation of Neurosurgical Societies, the WFNS, in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANSU. I'm glad to tell you that with my team, we already organized 57 webinars. Many of them are educational WFNS symposia. Today is webinar 58. It's organized in collaboration with the Cervical Spine Research Society. In this occasion, I would like to thank my friend, Professor Oscar Alves, for the opportunity to have such wonderful collaboration. First of all, let me welcome all our distinguished speakers. I will go by the order by which they speak. Professor Roger Hartel, Professor Virginie Lafage, Professor Juti Parthiban, Professor Oscar Alves, Professor Michael Schubert, Professor Javier Olvera, Professor Ali Baj, Professor Gregory Mondes, Professor Jeronim Milano, Professor Luis Pimenta, and finally, Professor Dom Korik. Thanks to all of you for your contribution to this neurosurgical activity and for giving much of your time sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. Today's program is very outstanding. It is divided into 2 sessions. At each session, we have a discussion. And as we can see from the screen, that all the topics are very interesting. I'm glad to tell you that this webinar is fully booked. We reached the maximum capacity of participation 1 week before the webinar started. We have, as we can see from this screenshot, 600 participants over Zoom. We're also doing live stream over the Facebook page of CANS. The address is seen over the screen, YouTube channel of Egyptian Society, and over the Neurosurgical TV of John Bennett. In this occasion, I would like to thank John Bennett. Actually, he's doing a great job in promoting our series of webinars. Our webinars are usually watched by thousands of neurosurgeons all over the world. To all attendees, we are glad to get all your questions and comments. It will be monitored through the chat panel or Q&A. This is the type of certificates we are offering, and it's important to tell you that this event is recognized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies. It's important to tell you that from webinar 1 to 50, we usually ask the participants to print their certificates electronically. However, my IT team, they did a professional job, and we started a new method. Since webinar 51, we are sending the certificates automatically to registrants by email after the webinar is finished. But it's important to tell you that certificates are only sent for participants who participate for more than 2 hours. Why? Because the organizing committee discovered that some participants just participate for 10 minutes and they are asking for certificates. So please, for all participants today, if you want to get certificates, participate for all the webinar from the beginning to the end. And important also to draw your attention that the names over the certificate are going to be the names of the owners of the emails. And so please register from your personal email. This table shows the registrants since webinar 51, the number of registrants. Usually, we are doing our webinar series in collaboration with the Educational Committee of the World Federation of Neurosurgical Societies, or with one of the ad hoc committees or scientific committees, like we can see the Spine Committee, or one of the neurosurgical societies like Emirates Society, Ukrainian Society, and sometimes with universities like University of Miami. You can see that the maximum participation is for webinars which were organized in collaboration with the World Federation of Neurosurgical Societies. In last webinar, we had 1,136 registrants. Of course, not all the registrants are participating because out of this number, we had participants 552, and certificates were sent only to the number of 269 participants. Those are the participants who participated for more than 2 hours. Our next webinar, webinar 59, is going to be a World Federation Neurosurgical Societies Educational Symposium, and this is going to be done with my friend, Professor Luis Borba. He's chairman of the Education and Training Committee of the WFNS, and the topic will be traumatic brain injury. We have eminent speakers like Franco Servadier, past president of the World Federation of Neurosurgical Societies. We have Andrew Reisner. He is chairman of the Neurotraumatology Committee of the WFNS, and the two co-chairpersons, Laura Lipa from Italy and Andrew Rubiano from Colombia. I have Tariq Khan, the past chairman of the Neurotraumatology Committee, Virendra Sinha, the chairman of the Neurorehabilitation Committee of the WFNS, and we have Andrea Dimitriadi. He is president of the European Association of Neurosurgical Societies. I'd like also to tell you about the Pan-Arab Journal of Neurosurgery. I'm editor-in-chief of this journal. We published the December issue already, and you can submit your articles through the address seen over the screen. Submission and publication are free because it's an open access journal. Important to announce about Bogota, the World Congress, which is going to take place in Bogota, Colombia, from 8 to 13 March 2022. All of us are going to participate in this important event, and I encourage everybody to join us in this meeting. Important to announce about the Third Men's Congress, which takes place in Egypt, 27 to 30 October 2022. I am president of this Congress, and I'm glad to work with my friend, Professor Alberto Delitala from Italy, is president of the Mediterranean Association of Neurological Surgeons. All of you are invited to contribute to this important event. I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I give the mic to Professor Oscar Alves to say his welcome note. Thank you.
Thank you, Nasser. It is a real pleasure to work with you. You have been a real great educator, promoting all these webinars, very prestigious. So it was a real pleasure for me to enroll all the speakers we have today. They are real leaders in the spine world, in their field, as you'll see. And without any further delay, we should start with Roger. Roger Hartel.
I think Oscar Mahmoud Khorachi is president of CANS. I can see him. Mahmoud, are you here?
Yes, I'm here, Nasser. I won't take much.
We are honored to hear your welcome note as well.
Thank you very much. I think it's a pleasure, as always, to participate in the excellent series of webinars that you, Nasser, have organized through the Egyptian Society in collaboration with our Continental Society. And the Continental Society is really privileged to have a hard-working academician such as yourself, who really has brought the world together from all corners of the globe with excellent lectures and excellent topics for our young neurosurgeons. So on behalf of our societies across the continent and across and our young neurosurgeons from Africa and indeed from other parts of the world, I'd like to thank you, and I'd like to thank all the excellent faculty. I know Roger well. We've done many courses together, or several courses in Tanzania. He's really made a big difference in Tanzania with all that he has done through research. So it's a pleasure seeing you, Roger, once again, and always a pleasure listening to you. So welcome everyone, and thank you for participating.
Thank you very much, Professor Mahmoud Khorachi, president of CANS, for these kind words and for this kind introduction. Now I give the mic to Oscar Alves to start the scientific sessions and to introduce our first speaker.
Okay, so we'll start with a friend from New York. Roger Hartel is director of neurosurgery, spine at Weill Cornell University. Roger is really a pioneer in MIS spine surgery. He's responsible for the EU spine curriculum on MIS. And I can tell you that he organizes every year in December the best MIS course in New York City. I've been privileged to have the guest speaker there, but you should really attend and look at closely the announcement. So please, Roger, give us your opinion, your frontline opinion on robotics and artificial intelligence in spine surgery. Thank you.
Thank you, Oscar, and thank you, Nasser, for this very kind invitation. Can you hear me okay?
Yes.
And good seeing everybody, Dr. Koresh, yes, of course, and the others. All right, so I'll talk to you a little bit about navigation and augmented reality. I've been using navigation for pretty much since I started doing spine surgery as an attending, almost 20 years ago. And I think it really has become a very, very important part of what we do in the operating room in spine. And I think there's a great potential for navigation to facilitate spine surgery, to make spine surgery more predictable, and to really help us with minimally invasive and also with complex spinal operations. This is the cover of a book that's coming out in a few months that summarizes the current status of minimally invasive spinal surgery. And we also discuss in this book a lot about navigation, robotic surgery, and augmented reality. My presentation today is really based on our experience with 3D intraoperative navigation. So using a intraoperative fluoro-CT or true intraoperative CT scanner, and how can you use that to facilitate the operation that you do in the operating room. Now, some of you may be looking at YouTube videos. There's a series of videos by Simon Sinek. He's like a motivational speaker in North America. And he talks about the why question. He says that a lot of companies, a lot of researchers in science, they focus on what we do and how we do it, but very, very few people really talk about why. And the question then is, why do we navigate? And I think we have to keep that really in mind in order to intelligently then introduce navigation, robotic surgery into the operating room. And obviously, in my opinion, the main reason is safety. And studies show that if you use navigation, you can more accurately place implants, for example, which makes surgery safer. I think that if we do it correctly and if we really intelligently introduce navigation into the operating room, we can also become more efficient as surgeons. In the operating room, but also the operating team. So it can save time. I think it can be cost effective. There's studies that show that. And then finally, of course, it enables more complex and also minimally invasive surgery. So it can make you really a better surgeon. And more we know that, and companies always talk about that patients really request navigation or robotic surgery. And that's an important factor as well, of course. So I think that in summarizing really what I want to talk to you about is if used correctly and efficiently, you can use navigation to make your implants look more precise in the operating room. It can facilitate minimally invasive and complex spinal surgery. We have introduced the concept of total navigation, meaning you do an operation with navigation from the skin incision to finish. So no fluoroscopy anymore. You don't wear any lead as a surgeon. And you can do that if you modify your workflow slightly and really take advantage of navigation. And obviously, a lot of this depends on, you have to have the right equipment. And I know that may be a challenge around the world, but once you have the correct equipment and you modify your workflow, I think total navigation really allows you to kind of really take advantage of the benefits of navigation. Robotics is a very, very big thing, of course, these days, and now augmented reality. And I want to show you a few cases that we did with augmented reality, where I think augmented reality really points in the future as to what we will be doing with navigation and with intraoperative navigation in the future. Now, this is obviously what we don't want to see, and this is exactly where navigation comes in, especially in North America. There's a huge concern about implants being misplaced, not only because of patient safety, but also because of litigation and costs associated with that. We have published this study that showed that navigation decreased perforation rate, so misplacement rate, of implants in the lumbar and thoracic spine from 15 to 6%. And this was published, almost 10 years ago, but there are many, many more publications that always point in the same direction. Now, robotics have gained a lot of interest, and I personally think that is very, very much pushed by industry. And there are a lot of really good systems out there, and I think they provide benefits to patients and to surgeons. But I think you have to keep in mind that robotics is really a subset of navigation. If you really want to take advantage of the whole spectrum of navigation, you've got to keep in mind that robotics is only a small portion of that. There's freehand navigation, there's augmented reality, there's virtual reality, there are all these things. So you got to don't just focus on robotics. I think robotics are important and are going to become more important, but it's really only a subset of what we can do with navigation. If you look at the whole area of navigation, you have to understand there's imaging technology. So that's the intraoperative fluoroscopy that you get, the intraoperative CT scan, the fluoro CT, there are cone beam CT scanners, fan beam CT scanners. There's all this imaging technology available. And on the other hand, then you have the navigation technology. So there's, the Medtronic has a system, BrainLab, Stryker, they all have great navigation systems available. And then obviously the imaging and the navigation technology have to communicate, and that's being done through software that then allows you to communicate, to do planning and so forth. So you really have to look at this navigation area as a whole. Then there's robotics, there's augmented reality, there's freehand navigation, and all these provide particular benefits for particular surgical situations. And I think as surgeons, we should not try to separate those out, but really keep this in mind. And if you look at robotic surgery as to what patients really understand as robotic surgery, which is, for example, the Da Vinci that allows surgeons to remotely operate, obviously what we in spine surgery call robotic surgery is totally different. It's just essentially an arm that's being held in place. So we're still, from really truly robotic surgery in spine, we're far away from that. But I'm sure we'll get there though. Studies have shown that if navigation is being used efficiently, effectively, it can be cost effective, especially because it reduces the number of revision surgeries. Really, the mechanism by which navigation is cost effective is that your implants are going to be more precise and you avoid revision surgery. Now, our concept of total navigation, we introduced maybe about 10 years ago, where we realized that if you use navigation correctly, you don't really need any fluoroscopy in the operating room. You don't have to wear lead. You can do everything for a simple, straightforward case, from skin incision to screw placement to cage placement to the decompression, everything with navigation. And we've published this, and we've done this very, very effectively. We use an intraoperative CT scanner here in New York. However, there are many, many other devices out there that can be used very successfully, of course. And the other thing that made a big difference for us in navigation was to use a pedicle screw that is being navigated in a single step. So you don't have to navigate separate instruments. You do this particular pedicle screw, and there are a number of companies that have these screws available. This particular pedicle screw has an integrated K-wire. So you just navigate one implant, and it facilitates the workflow and it cuts down on the time. And that has made for us a huge difference for the cases that we do. I do a lot of T-lift surgery, but also lateral surgery, percutaneous instrumentation for trauma. So we do this all now with this single step navigated pedicle screw. But we use navigation for localization of pathology as well, for thoracic disc herniation, for spinal tumors, for cervical foraminotomies. I did 2 cases yesterday of cervical foraminotomies. Navigation makes your life so much easier in the operating room because you don't have to hassle with fluoroscopy back and forth. You navigate everything. And then at the end, if you want, you can get another spin to make sure that you decompressed everything. Now, for the remainder of the time that I have, I want to talk a little bit about augmented reality, because I think there's a huge role for augmented reality. And augmented reality, the way that we use it in the operating room, means that you look at the pathology, you look through the microscope, or you look at the screen, and then you then you merge it with some kind of superimposed computer-generated image, and hopefully they'll make your life in the operating room easier. Now, we're all familiar with the goggles, and surgeons have used this now and using it already very successfully to put in pedicle screws with augmented reality. Now, I'm really interested in augmented reality, though, using the microscope, because I think it can really help you with microsurgery for tumors, but also for other pathologies. And we've used augmented reality for the MIS TLIF surgery that we described as part of the AO MIS curriculum. And as you know, that the MIS TLIF procedure is a very, very well described and really almost automated procedure. You're always looking at the same landmarks. You put in the pedicle screws, then you look at you drop your tube, you look at the facet joint, you remove all these bony structures, then you get into the disc space, you put the cage, and then hopefully over time, then you will get a good fusion. Now, with what is really remarkable about MIS TLIF surgery is that it's really based on particular bony landmarks. And these bony landmarks can be identified preoperatively on an intraoperative or preoperative CT scan. It can be marked and then can be projected through your microscope into the view that you have during the surgery. And then you can identify these landmarks, and that can facilitate the surgery in patients who have maybe more complex anatomy, but also in straightforward cases, especially for the assistant and for younger surgeons who want to learn how to do an MIS TLIF very effectively. And we've done about 30 cases now where we identify all these bony landmarks. So that's the lamina, the pars, the pedicle, the disc space, and the contralateral pedicle. So we identify all these structures on a preoperative CT scan or intraoperative CT scan, and then we project them into the view through the microscope as the surgeon is doing the operation. So we're looking, this is in the operating room, just an example, that's the screen that we're using. And you can see here, you can click in and out certain anatomical structures. So these are the contralateral pedicles, for example. These are the pedicle screws that we planned beforehand. And as the surgeon is doing the decompression, you can already see the lamina, the pedicles, the disc space. So you can visualize all these anatomical structures that will be important as you proceed with your MIS TLIF surgery. That's the reference array on the microscope. And this is the resident getting the case started. And then on the screen, you can project in all these landmarks. And I don't want to take more of your time, but I just want to show you a few images that kind of illustrate then what it looks like in the operating room when you really integrate augmented reality. The TLIF obviously starts by placing pedicle screws with navigation, and then you bring in the microscope and you look at these landmarks. So these landmarks initially to remove the facet joint are the inframedial edge of the lamina and the pars. You mark those with augmented reality, and then you remove the facet joint. Then you expose the caudal pedicle. So this is the pedicle projected on the microscopic view, and then you use that to orient yourself to find the disc space, and you go on, and then put in the cage. That's the disc identified. That's the dura that's being retracted, and then you proceed from there. You put the cage in, everything with navigation through a small tube, and then basically you go from step to step using the augmented reality that you have displayed through the microscope. So that's the and you remove the facet here with the drill, and then finally and then you remove the facet, and then you identify the pedicle underneath. That's the pedicle now here coming into view as you focus in, and you find the disc space, and you do the discectomy, and then put in your cage. So I think I'm gonna stop here, Oscar, and I don't want to take up too much time, of course, and I hope I was able to give you a little bit of an idea as to how we can integrate augmented reality into the workflow, not only to put in screws, but really to make us better microsurgical surgeons. Obviously, we use it for tumor resection through tubes as well, but I thought that the MIS TLIF is a great operation because of those bony landmarks that you can really display through the microscope. So thanks, Oscar. Thanks for everybody's time.
Thank you, Roger. Wonderful lecture, as always. I think you really made the case for the need of navigation and the new prospect of augmented reality. I think one of the things that adds a lot to the safety and also to the better results is in the planning stage. You know, the day before where you plan your case, you dedicate some time. We were not used to do that so much before. So, you know, can you comment on that, on the educational part of the navigation and augmented reality?
Yeah, for sure. I mean, that's the one thing that robotic surgery really brought into play is the need to really plan your case before surgery, right? I think and then with augmented reality, it's the same thing. Like we spend time now before the surgery to identify the pedicle, to identify all the bony landmarks for our surgery. And sometimes in doing that, you realize that you modify your surgical plan a little bit. And I think that's exactly what we haven't done. We used to just look at the films and then go the OR and you figure it out while you're there. But now with really careful examination of preoperative imaging studies, trying to integrate the augmented reality, and for some surgeons who use robotic surgery, who put in pedicle screws, who plan pedicles beforehand, it makes you a more careful and a more thoughtful surgeon for sure.
Okay. Anyone from the faculty wants to?
If I may, I raise my hand. This is Moody. A great talk, Roger, as always. I just wonder whether you know the navigation groups such as Medtronic and BrainLab, whether they've actually managed to incorporate augmented reality into their equipment, and whether this is a package that you can negotiate for directly rather than just go for Medtronic and then go for an augmented reality system. Do you know whether they're working on it or?
Yeah, I think I can give you like a rundown. So there's really good augmented reality with goggles if you're interested in putting in screws. There are several companies that have, I think, pretty well thought through systems now. If you want to use augmented reality on a macroscopic level to put in screws. What I'm showing here is really using the microscope, kind of like what brain surgeons do. They use augmented reality for brain tumors. So we're doing the same with the microscope for spine surgery. And I'm a consultant for BrainLab. So BrainLab gave us the software that they use for brain, and we're using it for spine. But it's not really customized yet. It needs a lot more refinement. I mean, there's so many things that we could do to make this so much more user-friendly. So what I was showing you to utilize this for example, MIS T-lift surgery, it's not really user-friendly. We've done 30 cases, and now I'm hoping that BrainLab is going to work with us on refining the software. What I envision is one day we're going to go to the operating room and we're going to do a microdiscectomy with augmented reality, but we're not there yet. The other thing that we need to be able to merge intraoperative X-ray with a preoperative MRI scan, which the companies, the physicists say that that's really, really difficult for some reason. Once we can merge an intraoperative X-ray with a preoperative MRI scan, then augmented reality is going to be a no-brainer for every microdiscectomy. But it requires more refinement of the software part, and we don't have that yet.
Great, thank you.
Thank you. So I think thank you, Roger.
Sure.
Have a good day. So I think we need to move on to Professor Virginie Lafarge from New York as well, but she's today in San Diego. And every time I hear Virginie, I always learn something. She's really the most prolific research in spine balance with clinical impact. She's Senior Director of Spine Research in New York Hospital for Spine Surgery. And she's talking to us today about the sagittal spinal pelvic alignment from theory to clinical application. Please.
Thank you. Thank you very much, Oscar, and thank you for having me. It's always a pleasure. So today I'm going to talk about sagittal alignment, and I'm going to try to make sure we agree on a few concepts. Because I think like over the past maybe 10 to 15 years, we've done a good job at confusing everybody in the sense that, you know, every year someone come up with a new parameter and then like, you don't know what to do. You don't know what to start. And so when it comes to sagittal alignment, so these are my disclosure, you know, the question is, let me just move my windows, is really, what is an ideal global alignment? And we can argue, you know, we can talk about like the shape of the pelvis, the curvature of the spine, and should you use the Rousseau approach, should you use a gap, but I think at the end of the day, we need to keep it simple. And so for me, ideal alignment is, well, the patient needs to have a trunk that is more or less vertical, need to have an horizontal gaze without compensation. So you need to be like a standing posture that do not require compensating or recruitment of the muscle. And so if we agree of this definition, then we can start to do some analysis. And so the question is like, well, this seems like very simple, but how do you achieve this objective in setting of a spinal pathology? So let's look at a few schematic representation. And I would say like, if the foundation was horizontal, that would be very simple. So to have an horizontal gaze and a vertical trunk, you just need a straight line. But unfortunately, it doesn't work like that on our patient. Why? Because the spine is sitting on the pelvis, and the pelvis by itself is a little bit of a complex structure. And we have to rely on what we call the pelvic incidence, which is basically the shape of the pelvis, or you can think about the pelvic incidence as being like the orientation of the sacrum within the iliac. So this is an example of someone with a small pelvic incidence. So the sacrum is kind of horizontal. And if you take a different patient or a different subject with a large pelvic incidence, you can see like the shape will be totally different. And therefore the foundation of the spine will have a totally different orientation. So now if I take my small pelvic incidence and I put a straight spine, well, you can see it doesn't work. It doesn't work because the trunk tilts forward. And so at this point, there is two solutions. The patient can compensate, meaning can turn the pelvis backward. This will bring back the spine in a vertical position, or the patient needs some curvature. And if I do exactly like the same schematic representation, but now on a large pelvic incidence, so remember, a large pelvic incidence, you're gonna have a sacrum that becomes more and more horizontal. Now it's even worse. If I put a straight spine, well, the trunk, you know, is falling forward, but that's the same solution. Either the patient will compensate, turning the pelvis, creating more lordosis, which can be done like through the spine by the patient himself, by hyperextending the spine, or through surgery. And so let me show you like two examples. So this is a patient with an adult spinal deformity with a very large lumbar curve and in the sagittal plane. You know, I don't do any measurement for now. I'm just going to show you like, well, the spine is vertical, so that's pretty good. But it's vertical because the patient is turning the pelvis backward. Now, if I remove this compensation, that's the real alignment that the patient will have. Now I can show you a totally different patient. So this is a patient now with a very large pelvic incidence. So remember, a large pelvic incidence, the sacrum is becoming more and more horizontal, so a very large sacral inclination. And what is interesting on this patient is that, well, again, the spine is more or less vertical. The patient is able to maintain an horizontal gaze, but look at what the patient is doing. He's hyperextending here the proximal part of the lumbar spine. And so the patient is compensating for lack of lumbar lordosis at the distal segment. And so what did we learn? And I really think like, oh, sorry, if we just keep on those key concepts is that the objective is to have the trunk vertical, to have the head over the pelvis. But we also learn with that number that if you have a larger pelvic incidence, you need more curvature. And so if we agree on those key concepts, the rest will be like to learn a few parameters, but I really think that we can do a full analysis without having like to use like too many parameters. So one of the key questions when it comes to sagittal alignment, and in 90% of the case, it's going to be like your key question is, how much lordosis someone needs? And so we have like this old concept that say like, you know, you need the lordosis to be within 10 degrees of the pelvic incidence. And I would say, well, this is appropriate for if you have an average PI. So if you have an average PI, you want the lordosis to match the pelvic incidence. So very easy, you measure your pelvic incidence, and this is going to tell you how much lordosis you need. But you know that we have patients with very small PI or very large PI. In this case, if you have a small PI, again, you measure the PI, and the lordosis should be equal to PI plus 10. So a large one should be equal to PI minus 10. So we're still within the 10-degree range, but now just based on one parameter, you can only tailor patient by patient the amount of lordosis that the patient needs. And you can say like, well, you know, this is not really applicable to the type of surgery that I'm doing because maybe you don't do the big deformity. Maybe like your practice is mainly around like degenerative condition. And I'm going to show you a paper from Dominic Rottenflew. He did an analysis on patients with degenerative spondy that had 1 to 3 level fuse. And then he wanted to look at patients with adjacent segment disease. And the way they define adjacent segment disease is, well, if the patient needs a revision surgery for adjacent segment disease. So not like the subtle one that you can see on MRI, like really the symptomatic adjacent segment disease. And what he realized is that in patients with 1 to 3 level fusion, if you don't restore the proper amount of lumbar lordosis, so in the sense that if you fuse the patient in a flat position, then you increase the risk of this patient to need a revision surgery by about 10 times. So this has really like a direct clinical implication. So we talk about like the amount of curvature, the amount of lumbar lordosis. Now the next question is like, what is the distribution? Where do you put the lordosis? You know, we have 5 lumbar discs, like do you put like 20% at each level? You know, the quick answer is like, no. So what do we know? If you look at the literature, we know there is like this old rule that say like, you need 2/3 of the lordosis at the level of L4-S1. And if you want to go a little bit further, we can read like the work from Dr. Russoli, who talk about what is the apex of the lordosis. So again, like we have 5 lumbar vertebrae, and that would be very easy to think like, you know, I'm going to put my apex at the middle at L5. But this will not be like, L3. This will not be applicable for most of the patients. Why is that? Because if you have a small pelvic incidence, usually the apex will be at L4 or maybe like between L4 and L5. A patient with an average PI, so the vast majority of the subject, the apex will be at L4. And it's only in patients with a very large pelvic incidence where the apex will be at L3. And so, you know, where do we stand from a very pragmatic point of view? Because I do like to have very simple message. It's very difficult like to work with the apex because it's a moving target. So we did a study with Sébastien Pessanti, who is a spine surgeon in the south of France, where we looked at the distribution in asymptomatic subject between L1, L4 and L4-S1. And what we found is quite interesting. First, we found that the L4-S1 segment in asymptomatic subject doesn't change with pelvic incidence. It's always equal to 35 degrees. What changed with pelvic incidence is that when you go from a small one to a large PI, then the proximal lordosis, L1 to L4, will start to increase. So as the PI increase, the L1, L4 lordosis increase. And so that's very interesting because now if you're dealing with 1 to 2 level fusion, so L4, L5, L4, S1, then you know that your regional alignment should be more or less equal to 35 degrees. So we keep it like very, very simple. As the PI increase and as your length of fusion increase, then you need to restore more and more lordosis in the proximal part of the lumbar spine. So let's look at this patient. That's the same patient that I showed previously. Now I can show you like some more detailed measurement. L4S1 in this subject is about like 23 degrees. So quite not what we want. It's about like, 10 to 12 degrees less than whatever we want. But the patient here is able to compensate by increasing the lordosis above. So the distribution of the lordosis here is wrong. So this is an extreme case. So, if you want to match those two numbers, most of the time you will play with the lumbar lordosis. So increase the lumbar lordosis at one part, decrease the lumbar lordosis on the other part. And sometimes in some extreme case, what you can do, you can change the PI. So this is what was done by Dr. Schwab. You can see like the PI was 83 degrees. He did a sacral osteotomy, remove about 20 degrees of the pelvic incidence, and look at the alignment now. Look at the alignment, but also look at like the regional lordosis. L4S1 now is about like almost 35 degrees, so 33 degrees. So this concept of restoring not only like the amount of lumbar lordosis, but also the distribution is quite important. This is a patient that have an average PI about 50 degrees, and the lordosis from an angular point of view is totally fine. The lordosis matches the PI. But look at the distribution. Even visually, when you look at the X-ray, this sounds like very, very, very weird. Remember, we want about like 35 degrees at the distal segment and a distribution of 1/3 to 1/3. This patient, everything is reverted. Has too much lordosis at L1, L4, and too little at the L4S1. And this is by itself a risk factor for junctional failure. We tend to forget about the thoracic kyphosis. So the very rough estimate is that the thoracic spine, thoracic kyphosis is about 2/3 of the lordosis. And on average population, T1 to T12 is almost like 50 degrees. And so, if you have to just retain a few parameters, we have to talk about like the lordosis versus the PI. We have to talk about the pelvic retroversion and the SV. And I would say like, I'm not bombarding you with 10 different parameters. And I would say that's kind of easy. But the key is to know this parameter very well. There is no magic recipe. So that means that you need to know the meaning. So PI, LL, TK basically is telling you the shape of the spine. Pelvic retroversion is telling you, is the patient compensating? And the SVA is just the result of the spine plus minus the compensation. So let me show you like what I mean. This is a patient, 72-year-old patient. And again, I'm not going to do any measurement. I'm just going to show you the spine. And you can see like there is absolutely no lumbar curvature. So it's kind of like a long, flat thoracic and lumbar spine. But what is interesting is that you have a huge SVA, so the trunk tilt forward, and the patient do not compensate it. So no pelvic retroversion. So when you have a large SVA and no compensation, this is a red flag. A lack of compensation means there is something else going on. So this can be like a lumbar stenosis, which is a case, because when a patient have a lumbar stenosis, they're gonna flatten the spine to open the neural element to relieve the pain. This can be a sign of hip pathology or neurodegenerative disease. And that's what I mean when I say like, you need to know those parameters like very well. This is another case. So another case, like we can do all our measurement, but basically like we have a small mismatch. And if you just look at the global lordosis, say like, I just need 10, 15 degrees more. Well, this is exactly what was done. But in this specific case, we made a mistake. In the sense like we ignore the fact that the patient was compensating from L3 to L4. So if you ignore this fact and you don't restore the proper distal lordosis, so you can see it was L4S1 after the surgery was 22 degrees. Well, now you've done a surgery, or we've done a surgery, a 2-level surgery, and the alignment is not even better. So again, like the key here is like, if you go through the process of doing a surgery and the fusion, then we need to think about the alignment. We also need to keep in mind that spine surgery is not going to fix like all the problem. So if you have a patient with degenerative disc disease, with degenerative change in the muscle, you know, spine pathology are not just a fracture. You know, they affect like everything in the spine, including like the soft tissue. So restoring the normal alignment and putting like screw and rod, maybe sometimes is not appropriate. So that's why we like to think about like age-adjusted alignment, you know, because maybe you cannot take a spine with deformity or degenerative change in a patient that is 70-year-old and put it back to a level of 18-year-old alignment. And we demonstrate that, you know, if you do not correct enough, so under correction, the patient are gonna have worse clinical outcome. But if you correct too much, there is no incremental benefit from a patient reported outcome point of view, and then you increase the risk of functional failure. So in conclusion, I still believe that the list of measurement that you can use is short. But really, you know, and I'm going to insist on that, you need to know them well. So to know like the PILL is not sufficient. When I mean like you need to know the lumbar lordosis, you need to know the relationship between lumbar lordosis and incidence. You need to know like the distribution of lumbar lordosis. You need to know that sometimes the patient will compensate within the spine. Then in terms of pelvic tilt, well, retroverting the pelvis is a normal expectation when there is something wrong with the spine. So patients that do not compensate like should raise a red flag. And the SVA is basically like the result of everything. So going back to the patient that I showed previously, remember like the one that was compensating with the pelvic tilt, you know, then you go back to the root of the problem. The root of the problem in the sagittal plane was a lack of lumbar lordosis, and this is how the patient was treated. Thank you.
Thank you, Virginie. Always very, very insightful. As I said, always learn from you. And what I was interesting to understand was not the orientation, the implications for treatment, but you also showed this, raised the question of that Parkinsonian patient. So this can help you also to make good diagnosis. That's something.
Yeah, so you know, we don't rely on X-ray or imaging for a diagnosis, but it's an additional element. You know, it's an additional element. So basically, and that's where it becomes like complicated. It becomes complex when we put too many numbers. You know, but basically the rule is like, if when you look at the X-ray, it's weird, it's strange, then there is something else. And it's difficult to define what is strange, but we're good at looking at those images. We're not very good at putting numbers.
Like it's difficult to integrate different numbers and different, for sure. So we have here an audience from all over the world, different practices, different standards. So would you consider that every lumbar degenerative case is a deformity case? And in that sense, you should do a full spine standing X-ray of the patient? Or just another question as well, if you, for example, have a patient that spends 8 or 10 hours sitting in the office, is it important to have an X-ray on that position? Just to incorporate in the decision, you know, what's the activity of the patient?
Yep. So I would say like we have to be very pragmatic. You know, there is like the ideal world where, you know, you have like some fancy X-ray machine, but this is not real world. And I will propose like maybe to work backward, in the sense like if you as a physician, you decide that the patient needs surgery, and if the surgery involves fusion, so putting screw and rod and fusing the spine, then the minimum you need to have, it's an X-ray that includes the lumbar spine and the pelvis. If you can, then get lumbar spine, pelvis, and thoracic spine. You know, he has to work also like with whatever we have. So, because I don't want people to start to think like, I'm going to do an X-ray, And if there is a malalignment or deformity, then I can do a surgery. Think about the other way. If you're planning to do a surgery and fuse the spine, then I truly believe it's important to at least have the lumbar spine in the pelvis.
Very good. Thank you. Any other question from the panel, from the audience?
Oscar, two participants are raising their hands. If you would like to let them, anyone to speak directly, they are allowed to talk now.
Can you help on that, Nasser?
Yes. Anyone raising hand would like to share in the discussion? You are allowed to talk. I have two participants raising hands. Please speak if you are available.
Good evening, Professor Rajni.
Very short questions, okay? Still a lot of speakers to go on. Thank you.
Yeah. Ma'am, I want to ask, what about the weight-bearing MRIs? Do we require weight-bearing MRIs also? Will they change the sagittal balance and expose the disease more, weight-bearing MRIs and weight-bearing X-rays?
So, you know, the advantage of taking an X-ray in standing versus a weight-bearing MRI is that you can see how the patient compensate. So you can see like the natural posture of the patient, which you cannot necessarily in the weight-bearing. What we like to do, again, in the setting of a surgical patient is to compare the alignment of the standing X-ray with the supine MRI, because let's say you measure the lordosis in standing and it's very flat. And then on the MRI, you see some curvature. Then you know that the spine is flexible. So this will change your surgical strategy. I don't see like a huge place for weight-bearing MRI for the sagittal alignment analysis.
Thank you.
Thank you.
And I can follow up by email. You know, I saw like a few questions, so I'm happy to do that by email if we're running out of time.
Nasser, I think we probably should move on to the next speaker. And it's my thank you, Virginie, so much. Enjoy San Diego. Thank you. So the next speaker is a good friend of mine from India. We have been working together in the WFNS Spine Committee. Jyoti is the senior consultant neurosurgeon from KMCH Hospital. He's the past president of Neurospine Surgeons Association of India. Very dynamic spine surgeon. Always a very good communicator, and he will talk us today about intermedullary tumors and the utility of intraoperative monitoring. Please, Jyoti.
Thank you. Thank you, Oscar, and thank you, Nasser. And are you able to see my screen on the?
Yes, perfect.
Yeah, thank you. It's a subject of interest for this present era, neurosurgeons, because we belong to the earlier era neurosurgeons before IYNM was even came into our teaching time. But then now we are shifting towards a different kind of experience with IYNM, right? So I like to send my greetings from India. This is the place where I come from South India. It's called Coimbatore in Tamil Nadu. It's a nice place. I would like to welcome you all in future. Now, the goal of intramedullary tumor surgery is refuting very clearly about the safe resection of the tumor and the best final result, that is the outcome, and preservation of the neurological status, whatever the patient presents with initially. So what way the intraoperative neuromonitoring is going to help us? Is it really needed? Number one, does IYNM reduces the complications? Does it limits the surgeon's all-out skill? Does it has limited benefits in special cases? So we like to see some literature and then personal experience. when we put this IVM, you kind of so many wires. The technicians, they do so many kind of wires which are required, which is very important, and you need a very good technologist and also a technician, and also the surgeon must be, and also the surgeon must interact very well with the technologist, which is very important during surgery. Before the IVM days, you try to operate with your skill, basically how you operate on that. But then once the IVM came in the practice, then there is kind of a policing on you while you are operating. So the first one was the SSCP. I heard some noise somewhere. Oscar, I think somebody's voice is disturbing me.
Yes, I'm trying to identify who's the person, but I can't see.
This is the SSEP, which is very common, and the first one, which goes through the dorsal column and medial lemniscus. The warning criteria is about the 50% drop in the amplitude of SSEP, somatosensory evoked potential, and 10% of prolonged latency. The sensitivity is around 75 to 94%, and specificity is about 50 to 100%. Overall, the consensus about the surgeons, among the surgeons, is you pass the surgical procedure if you get this warning criteria and divert it to other route as long as the MAP remains stable. So that means that you may have to do the MAP along with that. The limitation of SSEP is it has a prolonged acquisition time. That means, it takes some time to understand that there is some problem is going on. The motor evoked potential is that MEP is through the motor pathway is faster, and it is given through the multi-pulse technique. The warning criteria is the presence or absence and variations in threefold, and change in the waveform and amplitude variations. The sensitivity is about 75 to 100%, and specificity is 25 to 100%. The importance of this MVP is that very useful in the sconus medullaris and cardiac vena tumors when compared to the spinal cord tumors at different level. The consensus overall among the surgeons is to pass the surgical procedure if you have a warning criteria, and immediately you irrigate with warm saline, piperacillin, and increase the blood pressure, because majority of the potentials are taken from the muscle. So the stimulus has to come from the cortex to the muscle, and it is, you have the anesthetist agents and other things can always change it. So this is an important part of MEP. But the D wave is an excellent one. It has a functioning of the fast conducting corticospinal tract is being detected, and the direct single stimulation is used in this. Midline recording of the subdural or through the extradural up to T10. The reason for T10 is that you have enough surface of the spinal cord to pick up the signals. If you go below the T10, then we come to the cardiac vena and also the fibers, and we cannot pick up the signals. The diagrams which shows that you can see a pickup of the electrodes from the spinal cord. And this is not affected by the blood pressure, heart rate, or the drugs. So it's an excellent mode. And the warning criteria is decrease of more than 50% of the amplitude. And sometimes it is considered as the gold standard for all spinal cord tumors above T10. Now, the other things are the free running electromyography, bulbocavernous reflex, and also the mapping techniques. That is the dorsal column mapping, intramedullary motor mapping of direct stimulation, and you can stimulate the spinal cord inside when you operate, and you can also get the signs which is necessary for your decision making, or you can also do the triggered EMG stimulation. So these are some of the techniques. What kind of results we get is one is the true negative. That is that you don't have any warning and there is no deficit in the postoperative period. It is called true negative. True positive is that you have a warning sign and you have a postoperative deficit. The problem comes with a false positive. The false positive, you get variable results and predictive. And this can limit the total resection what the surgeon is aiming at. The false negative is there is no warning at all, but you'll find the patient to be in a very severe deficit postoperatively. And that is really problematic for the surgeon as a false negative. So these are the terminologies which is very important when we use it. Now, when we go to the literature, this paper which is studied in 2016 says that multimodal IONM is very important. It has a sensitivity and specificity of nearly about 99 to 100%. And so if you combine the motor evoked potential and SSCP, the results are very good. Your prediction is good. Your resection is good. That's what this paper says. Another paper, which comes from Korea, says when they keep it as 75% as amplitude warning on weaning criteria, it is compared with the non-IONM group, and they did not result in significant improvement in gross total resection of the tumor and neurologic outcome. So they are not very happy about because it is not helping to them. And also they have said that it is easier for them to operate on hemangiomas when compared to gliomas with IONM. Now, this is another paper which says that IONM helped in extensive operative resection with minimal complications with grade 2 hemangioblastomas. So that's a very good paper which comes in recently. The D wave prediction was good, but in spite of that, they had one patient which had severe deficit in spite the D wave was positive. So, this was a big shock to the surgeons, so we do not know. Hence, the correlation between the changes in the amplitude and the neurological deficit is still challenging to some group of surgeons. IONM has helped in preventing unnecessary manipulation of the part. So that means when we use the IONM, it's a police. It's a police to the surgeon. It genuinely shape the surgeon to do microsurgery in a better way. Another paper recently has confirmed the usefulness of IONM. This is the some of the latest papers. And an interesting paper is this one. This group is not happy, not much. IONM showed high, but not perfect sensitivity and specificity. IONM prevents neurologic damage, but can also limit the extent of the tumor resection. That means it will stop, it will make the surgeon to stop it if you have a false positive. So a prospective studies will have to define the definitive value of IONM as far as this group of surgeons who did in 2019. And also there is some talks about the alert time and the response. As far as the intramedullary spinal cord tumors are concerned, the low rescue rate, the rescue rate is very less. It's only 31.5%, which is not very comfortable for any surgeon. This is the end product of this particular prospective study in 2018. I would like to talk to you about what we saw in some patients in our experience. Here is a case of a cervical intramedullary tumor. It's an ependymoma. It starts from a C2 to C5. The patient had only a numbness clinically in the upper limb, but had no motor weakness, and the patient was walking very comfortably. You can see the tumor very nicely, more on one side. And this was operated microsurgically, and this was operated without neuromonitoring. When neuromonitoring was not available in our setup, we removed the tumor completely, total excision of the microsurgical total excision done. And then the tumor bed and spinal cord is closed. This is the immediate postoperative in 2012, immediate postoperative. And also, you can see that in 2020, that's about 8 years' time, there is no recurrence, and the patient has got a very beautiful results. This is without intraoperative neuromonitoring, microsurgical technique. And another case of ependymoma of the upper dorsal spine. This case is very interesting because it is not limited to one area. It is not limited to posteriorly. You can see the lesion extending anteriorly. You can see the tumor extension is very, very confusing, except the fact that you can see where exactly we find the tumor at the dorsal region. Now, this is the postoperative. You can find this postoperative is very beautiful. It's totally excised. This tumor was totally excised. Now, as far as the postoperative condition is concerned, this patient has improved very well over a period. The patient came with paraparesis and the patient improved a lot, and now it's walking. And this was done without intraoperative neuromonitoring. This is my diagrams, it's my feelings. Now, if you have the tumors which are in the posterior, you can see those diagrams which are seen, and those are the simple, very easy to operate without much of problem. The complex ones are the tumor which is seen on the right and the inferior side, where you see the tumor extended vertically from posterior to anterior. And they are the one which needs more careful dissection. So a microsurgical technique is very important if you are not doing. Now, when you start intraoperative neuromonitoring, then there is a different experience. For example, this case, you can see a large ependymoma. It extends nearly about 5 level with some cystic component. And you can also see in the axial cut, it is a large one which occupies quite a bit of the axial area of the spinal cord. And this is the microsurgical view of the posteriorly. You can see the dorsal vein, enlarged cord, and dorsal nerve roots are seen very well. And myelotomy, posterior pile opening and myelotomy. And then the stitches to the dura to hold the spinal cord straight so that your surgery becomes easier. And then the tumor is resected in a methodical way with microsurgical. Here we have used intraoperative neuromonitoring, both MEP and SSEP in this case. And the tumor was gently excised completely on the edges, that is on both sides of edges. We use CUSA because I have certain principles and we don't have much traction, but CUSA helps us in excising the tumor very well. So the tumor was completely removed with satisfactory operative outcome on the table. As far as the IONM is concerned, you can see very well, beautifully on the baseline. You can see upper there. We don't see any signal over there. But in the post-excision, you can find the signals coming up in the upper limbs. It's very nice. It's quite satisfactory. That means that it shows that there is an improvement. And SSCP also showing satisfactory. There's not much of problem. SSCP shows very nicely. But we did some triggers and triggers were also happy. This patient had a neurological transient weakness. That's the beauty. Now I go back to this. Here it looks pretty satisfactory. The IONM says that, okay, you have done a good surgery. But then in the post-operative patient had worsening of the neurological status, but it improved. It never was down all the time, and the patient was maybe about for 4 days, patient had weakness and then started improving. A patient is good now, post-operatively. So I personally feel that some of the manipulations you are not able to detect, but this MEP, whatever I found this, the surgical technique is more important in operating on intraoperative, operating on intramedullary tumors. Now, this is the post-operative of the same patient. You can see here very beautifully tumor is removed and the patient has improved. In spite the spinal cord is very, very thinned out. This is a good excision. And we have finally the results are good. But the signals were a little different. Though the signal encouraged, but there was a transient deficit. That's what I'm trying to say. A complex case of this kind in a pediatric neuroenteric cystic tumor, pretty complex. I could not get the operative picture here, pretty complex. We operated on this baby who came with a paraparesis in November 20. And here you can see there is an improvement in the waves. In MEP, you can find in the left side on the baseline, you have the amplitude is very less. On the lower side, post-excision is very good. And the D wave here showed satisfactory waves. So this patient, and in fact, it improved well post-operatively. So we had a very good result in this case. And this you can see that in field, you can see that the post-operative MRI of this patient in sagittal. Now, another case of a cystic lesion here. This patient was recommended for surgery very early, but refused for surgery. But when the patient came with a very bad paraplegia. This patient paraplegic, I can say, grade 2. Patient had this lower cervical upper dorsal lesion. It was a cystic lesion. You can see here a cystic lesion. Here we also use the D wave, and we did through the hemilaminotomy approach. And because it's very cystic, laminotomy was not done. And you can see in the microsurgically, you can see the cystic lesion. The cystic fluid came out. It was more for neuroenteric, but completely intramedullary. And after the cyst was removed, you have a very nice cord. So in this case, if you see the baseline value here, in the lower limbs, we didn't get any baselines, any waves. So that shows we had no improvement immediately after surgery. But if you look at here on this side, D wave showed a good improvement. You can see here, D wave baseline was okay. During resection also was okay. But after resection, you showed an improvement in the D wave. And similarly, this patient improved in the post-operative period. That was a very happy news for the surgeon. So here, more than SSCP and the MEP, the D wave have shown a prognostication value in this case. Now, a case of conus lesion. It was a hemangioma, conus lesion. This was excised. A small residual lesion was left because we felt that lesion we found very difficult to remove. We had some MEP changes, we stopped and removal, and this patient came out very well nicely. Yes, this is the one. You can see here, first it shows, and then later on, there is an improvement in the signals. So that means that this patient is going to improve, and this patient improved very well post-operatively. And you can see the signals are changing. The signals are better here in MEP. This is both at the baseline and also the post-operative MEP, which shows improvement. So it gives a prognostication that your surgery is good, and the surgeon is able to operate liberally with the MEP guidance. Another case of the epiconus lesion, a large lesion, you can see in the epiconus lesion. And here it was excised completely except a small residual lesion. This patient also was guided with MEP, and this showed a good prognostication. And this is a lipomas. And lipomas, we do see lipomas of different type. And if we do meticulously with IONM, with the meticulous surgical technique, we are able to excise it very, very nicely. As you see in the post-operatively, you can see the majority of the lipoma is excised and patient is preserved, and patient shows a good improvement. Now, finally, I would like to conclude by saying intraoperative neuromonitoring is an essential tool in present-day neurosurgery. In majority, it is policing the surgical procedure for the surgeon. And as far as I am concerned, personally, I am concerned because we came in the pre-IONM era. We started using IONM. There's a gross improvement in our surgical resection. We were able to go very boldly with the guidance, with the policing of the IONM. It's a great tool for the young surgeons to self-assess and improve the surgical technique at the beginning of their career. Now, when they start with the beginning of the career, because we did only microsurgical technique, pure microsurgical technique. Now you have a police. This policeman will guide you to do methodically. You never get tired. Continue to get a multimodal monitoring system. Certainly, it will reduce the complications in spite of low percentage of uncertainty. Thank you very much for your kind attention. Thank you, Oscar. This is a picture which I said because you have a different type of dogs and the pets, and similarly IONM is also very different, and the tumors are different. You enjoy neurosurgery. Thank you, Oliver.
Thank you, Jyoti. It was very, very informative, and as always, and very collection of nice cases, and also for being so honest in showing some problems that might come with this difficult surgery. So just to make the point, we have this worldwide audience. So you would advise everybody now to do these kind of tumors with monitoring, right? There is no place for no monitoring.
Yes, I am very clear. See, our generation, like Oscar generation, my generation, and when we started, probably we may not have had. So we were taught with a meticulous way of doing intramedullary tumor, I'm talking about. Now the present generation should start with IONM because it is a great police. It's a very great police, and particularly multimodal. I would prefer three things. One is the transcortical MEP, SSEP, and D-wave and D-wave. The other important thing is the trigger, or you can trigger, because I do quite often for the conus and epiconus lesions. I directly stimulate the spinal cord and also the nerve roots, because this gives me a very good dissection. Maybe in the next time when I happen to give a talk, I can show you the operative videos how we dissect during that time. So I would recommend that IONM must be an armamentarium, must be included in all intramedullary spinal cord surgery.
Okay, Jyoti, just a very practical tip. When you have a drop of potentials intraoperatively, that's not obviously related with any manipulation and excessive manipulation. So what you do you wait longer time to recover? Do you close and come next day? Because coming next day can be hard, can always be more difficult.
Yeah, now it's a very good question. Here, if I am using only transcortical MEP, right? You don't have any other help. Then you are in trouble. But if you have SSEP along with that, and also you have a D-wave, then they will supplement you to go ahead. For example, if MEP is giving you a warning sign, I'll always check with the anesthetist. Are you okay? Is the anesthetic? Is there a drop in the BP? Is there a change in the heart rate? Is there anything different in the anesthetic agents? Because they also has an important point in MEP. So I will not believe 100% on MEP. I wait for some time. But if the MEP recovers, I start operating again. But if I have a D-wave along with that, I check the D-wave. If the D-wave is good, I'll proceed with the surgery. So what important here is that's why I said that this has to be started from the young age. Young neurosurgeon must start now so that they get accustomed to the multimodal assessment by themselves. And then that can be used for continuing the surgery while we excising the intramedullary tumors. So we cannot. That's what in some of the papers they have written, they have stopped the surgery. So what it stopped the surgery means that you are limiting your surgery because of one signal. That should not be. So we have to have multimodals. Your interaction with your technologists, your technicians, your neurophysiologists must be important. So you must keep talking to them. So once you talk to them, they will guide you. This is okay. This is an artifact. Sometimes conduction artifacts will be there. So conduction artifacts can give you a wrong signal. When we use multimodal, it will balance. Yeah.
Very good. Can you unshare your screen, Jyoti, please?
Yeah, sorry. Yeah, 1 second.
Nasser, do we have any questions from the audience, or can we go next?
I think Oscar, in the Q&A, we have some questions. If you like to take it now or take it at the end of the session during discussion.
Yeah, maybe at the end of the section.
Okay, let us proceed.
Okay, so I think it's my time to present.
Okay.
Can I?
Our next speaker is Professor Oscar Alves. We are glad and eager to listen to your presentation, Oscar, actually.
Okay. Thank you, Nasser, once again. So this will be a very brief talk on the minimally invasive posterior cervical fusion, technique that we have been using for the last 4 years, let's say. I have no disclosures relevant for this presentation. When you do an open posterior laminectomy and fusion, you have clear benefits. Comparing with the anterior approach, avoids the anterior exposure risks. You can access to multiple levels. You can offer the widest canal decompression and high fusion rate. But you have also important drawbacks, like all the iatrogenic morbidity that you cause by muscle denervation, ligaments section, long operative times, increased blood loss, longer length of hospital stay, a rate of readmission at 30 days that it's not negligible, high infection rate, postoperative pain can be severe, even in 30% of patients. Sexual alignment results are equivocal, and you can have all the sort of screw-related complications. Being an MIS technique, posterior facet joint fusion shares many of the pros of this shopping list of any MIS technique. And of course, the cons that you don't have direct visualization and you are depending on radiation exposure. Theoretically, this could be a surgery that you could use a robot for to do it in the future. So if you look at the surrogate endpoints for outcome, like muscle damage, this technique, looking at different cervical muscles, really minimizes muscle injury. And this will lead to reduced muscle atrophy, which means less pain and less chance of long-term kyphosis. The length of stay, as you see here, in different indications for this technique, it's around 1 day of hospitalization. And curiously, is not related to the number of levels you are treating. This is basic DOR setup, prone position. It's important to mark on the skin the line of the midline of the medial wall of the facet joint, of the lateral wall of the facet joint. You always start with an incision that it's a little bit lower than the level you are operating because you have an ascending trajectory. And you go from medial to lateral. This will avoid the canal, the spinal canal. And you are protected from the vertebral artery by the pedicle in some way. And on the lateral X-ray, you should never go beyond the line that connects the posterior body wall. Also, in cervical spine, the nerve exits the bottom of the foramen. So it's really unusual to damage the nerve root or the vertebral artery. It's a quite stable construct, talking about biomechanical stability. If you compare with lateral mass screws, in this study, biomechanical study shows that bilateral posterior cages afford a comparable segmental stability to lateral mass screws. Also, if you supplement a single and multi-level ACDF with posterior cages, it will increase the stability. The clinical outcomes are good. You have symptom improvement that it's comparable to traditional techniques. Very good fusion rates that at 2 years you have virtually no translational motion in the spine, and you have an evidence of bridging trabecular bone of 98%. And why is that? Because if you compare the facet joint area with the area of your interbody cage, it's a very comparable surface for fusion. On the other hand, also, you have a shorter distance for bridging bone compared with an ACDF. And the bone has much better quality than cancellous bone from the vertebral body. The concern is can be the sagittal balance. In the studies that were done, there is no evidence of significant loss of cervical lordosis. As you see here, at 2 years, there was a very minor variation. And you have, part of this is because you have parallel shaped devices. And also, if you compare the analogy with interspinous process devices in lumbar spine that are prone to induce kyphosis, you see that these cages, these facet joint cages, are very, very close to the center of rotation of the segment. So the applied moment to the lever arm for cervical facet destruction is much less when compared with the interspinous process device, where the device is much posterior to the center of rotation of the level. Very low rate of complications, no reoperation, no device-related complications in this publication. Very, very almost vestigial or non-adjacent segment degeneration. And these are the scenarios that we have been using this kind of technology. When you have symptomatic non-union or adjacent level disease and you want to avoid reoperating from the front because there is an increase in different kind of complications like laryngeal nerve palsy, like dysphagia. You can use it also in failed total disc replacement whenever you want to do a 360 fusion, or even if you're doing an open laminectomy, you can supplement with this kind of device instead of lateral mass screws. Or, which I think is a great indication, indirect foraminal decompression infusion. Just to show you here, good literature on symptomatic pseudoarthrosis with good, with positive clinical outcomes and 100% fusion. This is just an example you see here, pseudoarthrosis symptomatic. Again, a case here, and it was nicely solved with this device. This is a case also that I took advantage of this technology. A patient with a straightforward case for disc replacement. She had this C5-6 disc arthroplasty performed with a very good recovery of the arm pain and neck pain and neurological recovery. But at 9 months postoperatively, she started to have very severe neck pain. There was an hypermobility of the device, almost 20 degrees. We did a facet block that produced a release of pain. And that's what we did. We solved the problem, avoiding reopening again from the front and increased the foraminal height even, and good fusion, and the patient became asymptomatic. As I said, isolated foraminal stenosis, it's a great indication. If you do a posterior foraminotomy, the reoperation rate can be very high, around 10%, but it's follow-up dependent. The more you follow up the patients, the more cases you need to redo. 10 years, almost 1/4 of the patients will need a reoperation. Also, when you do a posterior foraminotomy, there are limitations. The degree of decompression is limited by the amount of bone that can be safely removed, which is generally less than 35 to 50%. Bilateral decompression, there is a higher risk of instability if you have to do it. And it's not, it's a motion preservation technique, so you don't induce fusion. And I think sometimes fusion, you need to abort motion to solve the problem of foraminal stenosis. And of course, if you have persistent facet pain and axial neck pain is a contraindication for a posterior foraminotomy. So isolated foraminal stenosis, like the case of this, we tried this technology. We increase the foramen height, like we do when we do an ACDF, that's indirect decompression, increasing the height of the foramen, and with good results, as in this case of this patient. And we have done 3 levels, just a very small single incision by with different orientation. We could insert the 3-level implant with good resolution of the symptoms and satisfied patient. This was done by others in this study, rapid symptom improvement and very early after surgery. So my conclusions for this technology, it's a technology with a low morbidity, tissue sparing technique, avoids many of the approach-related complications with open posterior or with the CDF, provides indirect and bilateral foraminal decompression with good clinical results. The concept here is to increase height, whereas when you do a foraminotomy, you increase anteroposterior diameter of the foramen. So it's kind of a different concept. It can stabilize as well as ACDF or lateral mass screws, reducing the range of motion, the excess of motion, which sometimes is part of the problem. High fusion rates, affording immobilization, which is important to solve the long-term radiculopathy. It's cost-effective, it's disposable device and instrumental, quick operation, day surgery, very virtual post-operative pain, and a very short learning curve. Of course, this does not address the spinal cord compression, although in some way it can expand the canal dimension by reducing the buckling of PLL and the ligamentum flavum. But I would not do this kind of operation if you have significant spinal cord compression or major instability. Kyphosis is still an issue, does not cause kyphosis, but you cannot reduce it as well. I would like to ask you to send your abstracts. The deadline for submission for our CSRS Europe Congress in Barcelona will end in a couple of days, but you're still in time to send your abstracts for a meeting in a very vibrant city of Barcelona. And in a week tomorrow, I'm organizing a webinar on cervical screwology, biomechanics, indications, and technical tips at 3 p.m. London time with very good speakers. We'll have a nice talk around this technology. Thank you.
Thank you very much, Oscar, for this great presentation. And our next speaker will be Professor Michael Schubert from Germany. Michael, are you here?
Okay, hello, dear all. You can hear me?
Yes.
Okay. So I can start the presentation. I have to relieve the you can see my screen.
Yes, it's very good, but not we can see, now it's good. Yes.
Now you may see my presentation.
Yes, it's good.
Okay. So first I have to say thank you for this very nice and warm invitation. And I was listening this afternoon to these presentations, and I'm very impressed. I'm not a neurosurgeon, I'm an orthopedic surgeon, but for almost 25 years, I do mainly spine surgery. And since almost 20 years, I'm focused in endoscopic spine surgery. So I will give you now an overview of things I have done and things who have developed in the last decade or 2 decades of 20 years. Basically, the conventional microscopic dorsal lumbar open discectomy is still worldwide the gold standard treatment for lumbar disc herniation, as you all know. And I think I already saw 20 years ago, it's time to change. I don't know how is the situation really over the world, but still in Germany, the open microscopic discectomy is still the golden standard. I was traveling and I'm a teaching professor in China, in Brazil, in United States, and I gave talks and I had live surgeries all over the world. But I think we all do, it's very difficult to start with endoscopic procedures in spine. And I think I ask myself why it took that a long time and why it takes that a long time. Because I think the instruments and the procedure is too complicated. And this was a motivation for me to develop my own instruments and to make it easier. If we talk about disc surgery in spine, we have to make a division between a transforaminal approach and the most common interlaminar approach. The interlaminar approach, from my point of view, have no big advantage because you have to remove muscles, you have to take bone, you have to open up the ligamentum flavum, you need to push the dural sac by side to reach at least the disc herniation. If you come through the Kembin triangle, Dr. Kembin, he described it in 1972. It is, you don't have to remove that much. You are exactly at the spot where you want to be, where is the pathology in the ventral epidural space. So very important to know is that if we study the literature, endoscopic spine surgery is not equal endoscopic spine surgery. Because why? There are different philosophies. One of the first pioneers, Tony Young from Arizona, from the Arizona Phoenix Spine Institute or Arizona Spine Institute, he developed the YES system, Tony Young endoscopic spine system. But his philosophy was an inside-out technique. Many people, they don't know what is the difference. The inside-out technique means he goes through the forearm into the disc, removing or decompression the inside from the disc, from the nucleus, in the impressions that maybe also the extruded disc herniation will be diminished. I think this idea is not that good. Sometimes it helps to perform a decompression of the nucleus, but not always. The other technique is the outside-in technique, and this is the technique I personally prefer. Also, there is an interlaminar approach, a far lateral approach, and a lateral approach, and at least a full endoscopic approach or a particular endoscopic technique. At least you as a surgeon, you always have to make your own decision, which philosophy you would like to follow. The inside-out technique, the outside-in technique, a full endoscopic approach, a particular X-ray control approach. Professor Hertel had a nice talk this morning about robotic-assisted approaches. I think this could be also something for this kind of approach in endoscopic spine. Again, interlaminar, transforaminal, far lateral approach. And nevertheless, do you perform the procedure in general anesthesia or in, let me say, analgosedation? That means in local anesthesia. The patient is awake, I can talk with him, and after the operation, he does not remind everything. A lot of neurosurgeons and surgeons all over the world, they told me, are you crazy? It does not work. It works. And I did almost 10,000 cases like that. And I had not one nerve damage. So from my point of view, this is the best neuromonitoring to avoid any nerve damage. You can perform the endoscopic procedures in prone position or in lateral position. Here's a summary table. And from my point of view, the transforaminal approach for many indications gives you a big advantage. Only for central stenosis, it's not that good, but some guys, they start with the UBI technique. I tried, but I'm not that satisfied, or dorsal cyst or posterior, the dural sac existing pathologies. To reach any kind of pathology in lumbar spine, thoracic spine, you always will need a reamer or a drill. That's, from my point of view, necessary to get the right spot. Also, I always remove that much as necessary and less as possible. I personally use the outside-in technique, and I always do it under fluoroscopic control. Here are some publications I published in the last years. Some was only for lumbar disc herniation, then for recurrent lumbar disc herniation. Last year I have a publication with 5 years to follow up, and also I do perform the endoscopic procedures for patients only with back pain who normally came to my office with back pain, and they wanted to have an alternative for a fusion or artificial disc replacement, and I did an endoscopic decompression of the disc. And here you will see also how it starts. We start on the left side, as you see, with a microscopic discectomy, then with Tony Young in the vertebral system, with an inside-out technique, but with a lot of disadvantages. Then Thomas Hoagland, I was a partner of Thomas Hoagland for many, many years. And he developed the TESIS technique, and we developed the Maxmore technique. And now I have developed my own instruments with the big advantage that there are not that much of instruments anymore, and it's easier to learn. Here you will see also an overview of this existing instruments, and as you can see, the YES technique full of instruments, not only reamers and forceps, approach devices. This is a typical TESIS instruments from Joymax. Here's the Maxmore and the Septivation. So what is the advantage of this new and let me say new system? Now I have to go back. It's an all-in-one system for cervical, thoracic, and lumbar spine. You can perform it in local anesthesia. Less or no cases of iatrogenic neurological damage is seen with this kind of technique and instruments. You have a much smaller risk of infection. You can perform a direct approach to the extruded disc fragment or the pathology in the epidural space. You will keep the natural mobility and stability. There is no fusion or ADR necessary, but still possible. You will see an excellent decompression of concomitant foraminal stenosis, transforaminal or interlaminar approach, as what is your own philosophy is possible. I have never seen a bleeding problems what gave me any complication or a revision surgery. Only minimal disturbance of intracanal structure, less scar tissue, faster recovery, less failed back cases. So from my point of view, only advantages. Now I will give you some examples I have collected in the last few years. Here you will see a typical disc herniations patients coming into your office. And how I do it, I always make an X-ray control to make sure that my tip of my forceps are at the right spot. And I always have to see the free pumping nerve. So, for example, this is an intraforaminal L3-4 disc herniation. And what you see here, okay, my voice, I don't like my voice like that. What you see here, this is the extruded disc, and it is compressing here to the nerve. This was a little painful for the patient. And with a cooperation with the anesthesiologist, he gave a little bit more to sleep. And under video control, you can nicely remove this fragment. And this was many years ago. Dr. Menno Ippenberg from Netherlands. He was one of my doctors who came to me. He wanted to learn this technique. So he is behind me. I'm talking now with him. And this procedure took me less than 10 or 15 minutes. the patient was immediately free. Here, what you see now here is an extra-foraminal extruded disc herniation. Also here, you don't need to remove any kind of bone, you just have to perform a dilatation. And then you go in with your endoscope, again, my X-ray control, and I can nicely remove the extruded disc herniation. This was on the left side, the preoperative picture, and this is the lateral view and the axial view. You see the nerve is still a little bit swollen, but you see the neuroforamen is completely free. What you see here, this is the nerve root. The picture is not that nice, and this was the extruded fragment I have removed. This kind of disc herniation very seldom, more or less, let me say, lateral posterior dorsal sequestrated. It's not a good indication for transforaminal approach. This I did with the interlaminar approach. It's also possible with this kind of instruments and technique. And again, here I do my X-ray control, and you see this tip of my forceps exactly at the spot where do I expect from the MRI the disc herniation. And here also 5S1 with a high iliac crest. Some people colleagues say, it's not possible. You have to make a hole into the iliac crest. This is not true. It's also possible only with a transforaminal approach. You have just to change the angle. Here also 3-4 crania sequestrated, no problem. Here is a dorsal cyst. I also can nicely remove with the endoscopic system, not transforaminal. This is also an indication for interlaminar approach, and again, the control of the forceps. This is the intraoperative picture. Sorry, the video, I think, is not running. I don't know why. Here you see a particulary of the cyst. Here the nerve is coming, and I used also a side fire laser to remove the entire dorsal cyst. And what you see here, this is the posterior dorsal view to the nerve, and the cyst was completely removed. This is a cranial sequestrated disc herniation. This was during a spine meeting for endoscopic procedures I did here in Munich, and a lot of colleagues. It was a live performance. It's also still on YouTube. You may can see it from our internet page. And a lot of colleagues told me, L5S1 with high iliac crest, it is not possible. And as you see here, it's not through the iliac crest, it's also just a transforaminal approach, and it is possible when I could nicely remove the hole in the entire disc herniation. Here you see, because the difference is that the approach is not that far not that far lateral, and also here's normally a video, and here you see the nerve, so I could nicely remove the disc herniation. This is a disc herniation 4-5, far caudal sequestrated. I always prefer to remove the disc herniations from that level the disc herniation is coming from. It was not coming from L5S1, it was coming from 4-5. And you see with reamers and drilling, you nicely can perform. I took a part of the pedicle to come very far caudally, and you see with the forceps, I could nicely remove it, and this was a big disc herniation. And here what you see on this picture here below, this is a completely freed nerve root. Again, the control, the checking, everything is nice. Here is spondylolisthesis with the lysis at the L5. And this patient, he came to me because he had extremely leg pain on the left side, and he was suffering of the extruded disc herniation extraforaminal L5S1. and he visited some spine center in Germany, and everyone wanted to fuse him. And I told him, okay, this spondylolisthesis you're suffering for many years already, but this leg pain you have now since 6-8 weeks, I just would remove the disc herniation, and the fusion you still can do whenever you want. And I removed it, and sorry, no, the picture is not going over it. And the patient was immediately free. And I think until today, there was no fusion necessary. A little bit tricky disc herniation, because you see here in the middle picture, there is not the transversing, there's an exiting nerve root from the right and the left side, and there's the disc herniation was sitting in the what we call axilla. So for that, I used a little bit different approach, more higher, not to damage the L5 nerve root, and to come with the banded forceps down to between the transversing S1 and S2 nerve root. Here, a patient pre-operated with a big hemilaminectomy defect and a recurrent disc herniation. Also, these are very nice indication for endoscopic procedure. Here also in thoracic spine at level TH9-10, the approach is not that far lateral, it's more paraspinal, only 5-6 centimeters. You always have to be careful not to come too much over the medial pedicular line. And I could also, as you see here, nice remove the herniated disc fragments. And on this picture below here, that's the free nerve root. So note, almost all operation performed in lateral positioning of the patient. That's what I prefer. You also can do it in prone position, but I prefer the lateral positioning. And all my operations, I think only one patient, he was so much in pain, and I did in general anesthesia, but all these patients I performed in what we call anal sedation, or and not in general anesthesia. And you guys, you all believe me or not, I had not one nerve damage in almost 10,000 endoscopic spine cases. In conclusion, the transfemoral endoscopic spine surgery for me is an effective and safe procedure without significant complications, and may help to avoid major operations or open microdiscectomy independent of size or location of the herniated disc, foraminal stenosis as well, and in our center, the gold standard. For future publication and comparisons for that, because I'm reading from time to time the publications, it is very, very important to the very different endoscopic surgical techniques. Like I have shown you in this small talk now, explicit reference should be made to the technique used in all studies, like inside out, outside in, interlaminar or transforaminal, general anesthesia, and so on. So thank you for your attention. Hello.
Hello, Michael. Yes, thank you. Very nice talk. I might visit you one day in Munich. I was impressed.
Okay, no, I can't see it here. Okay,
So I think we have some questions at the end, and keeping on the endoscopy topic, I would like to ask Javier Kilo Olvera from Mexico. He will talk us about applications of endoscopy in cervical spine, which I believe it's a very nice topic and promising. Javier is a spinal neurosurgeon and professor of neurology, brain and spine care, minimal invasive spine surgery group in Querétaro, Mexico. He has also a university affiliation. Javier, please go ahead.
Hey, thank you so much. Let me share my screen. Dear Professor Schubert, can you unshare your screen?
sorry.
Thank you very much.
Can you see me?
Yeah,
Okay.
perfect. Can you see my screen right now?
Yeah.
But let me, yeah, okay. So thank you very much for having me here today. This is not my first WFNS and CSRS webinar, but I'm so glad to support any academic and event. Thank you so much for the invitation. So today I want to share with you my experience in cervical endoscopy for degenerative diseases. I want to start clarifying the major classification of spinal endoscopy for cervical spine and for other spinal regions. We want to talk about uniportal endoscopy and biportal endoscopy. Both are water-based endoscopic procedures, different to any other endoscopic procedure based on air medium. So what's the rationale? Why perform endoscopy in the cervical spine or in other spinal regions? Spinal endoscopic procedures are a set of highly addressed procedures for the surgical pathology, so we can address the target without extensive dissection of paraspinal tissue. So we decrease the collateral effect in the patient. So the goal is to reach the pathological anatomy with the camera. So it's very important. It's essential to confirm the location of the endoscope during our surgery. Preparative planning is very important because we reach only the pathological target. So one of the advantages of endoscopy is visualization. Outstanding visualization with illumination and magnification, enhanced with continuous fluid irrigation during the procedure. Cervical posterior procedures with endoscopy can be done under general anesthesia, and also we can use intraoperative neuromonitoring. And the clinical outcomes and radiological results, for example, for foraminal stenosis or central stenosis in patients with cervical spondylotic myelopathy, are encouraging in spinal endoscopy compared with microsurgery or open surgery, at least are similar. With the advantage of minimal invasive spinal surgery in endoscopy, especially the short-term follow-up for posterior endoscopic procedures. For example, we can find decreased postoperative neck pain after procedure, reduce use of narcotics postoperatively, among others. So, but also we have drawbacks, we have shortcomings in spinal endoscopy. For example, we have a steeper learning curve, especially for uniportal endoscopy and also biportal. Sometimes accessibility for all doctors is not good because in some countries, the high cost of uniportal systems make them unaffordable for some hospital or doctors for using these systems. The learning process is difficult for some doctors, especially when they don't have specialized training courses. And right now, the pandemics has reduced the opportunities for cadaver workshops or face-to-face courses. So it's very difficult for some doctors to learn endoscopy. All trainers need supervision by an expert, but right now for the pandemics is not possible. And also the misuse of the technique based on incorrect decisions. We have to remember that spinal endoscopy is just a technique and the endoscope is only a tool. So spine surgeons should be comprehensive spine experts to opt for different alternatives and the best for the patient. So let's start with some cases of uniportal endoscopy for cervical spine. Remember, as another posterior cervical procedures, you have to recognize bone landmarks. The major bone landmark to identify during your endoscopic procedure is the B point. That is the confluence of the superior lamina and the inferior lamina. And then you can start with your procedure. After put your dilator in a prone position of the patient, You can introduce your working cannula, your bevel working cannula is used as your finger. You can touch the bone, you can palpate and feel the bone, and then continue with your procedure. So this is an example of how we dock the docking cannula in a lateral C-arm view. And this is an example of how we dock the endoscopic, uniportal endoscopic system in an AP view from the C-arm. And the green line represents the midpoint of the facet joints. This is the point where you can find the B point. This is the first case. It's a case example about 88-year-old male with quadriparesis with a previous ACDF at C3, C4. You can observe at C4, C5, and C5, C6 central compression caused by hypertrophy of the ligamentum flavum in the sagittal view of the MRI. But in the CT scan on the axial views at C4, C5, and C5, C6, you can observe some calcification in the ligamentum flavum. So it's not just a buckling of the ligamentum flavum, it's a calcified ligamentum flavum because of a degenerative process. You can see that the worst central stenosis is at C4, C5, also in C5, C6. So after docking the endoscope, the first thing is to identify landmarks. You can see the inferior border of the cranial lamina. You can identify the superior edge of the caudal lamina and the narrow interlaminar space, and both lamina confluence in the B point. Then you can start with drilling out your bone landmarks, starting with the cranial lamina until reach the attachment of the ligamentum flavum in order to perform a ULBD procedure, a bilateral decompression through a unilateral axis. After identify the ligamentum flavum attachment, you can see also the epidural space. This is the base of the spinous process. This is a landmark to cross to the contralateral side in your ULBD procedures. After that, you can start with the same process in the caudal lamina until reach the inferior attachment of the ligamentum flavum and identify the epidural space. Then you cross the midline in the inferior side, and you can reach the contralateral side and start with decompression. You can use several surgical tools in uniportal endoscopy, but the difference against biportal endoscopy is the uniportal, you're required to introduce your surgical tools through the integrated working channel. For some doctors, it's difficult to reach some skills to do that, especially in cervical and thoracic posterior procedures with the endoscopic technique. So that's the reason that there's other options that we want to comment in the next slides. So after that, you can perform your flavectomy and decompress your dural sac. Sometimes it is possible to combine your procedure with other techniques. For example, in this case, we perform also foraminotomy to decompress the exciting nerve because the patient has mild radiculopathy symptoms. And this is an intraoperative video, just an example to show how we decompress the cervical spine for a ULBD procedure, and are the same steps that I commented before. We can remove the flavum in a block, but this is not the goal, is perform a good decompression. And finally, you can see the pulse of the dural sac. You have to avoid push the dura during your procedure to avoid any risk for damage the spinal cord. This is the immediately postoperative CT scan. You can see the site of the laminotomy, and we remove the ligamentum flavum in the contralateral side to complete the contralateral decompression. And this is the immediately postoperative MRI. You can observe enough decompression, central decompression in the patient. And this is the axial view of the MRI. also in the postoperative status, and you can compare the central decompression at C4, C5 in the postoperative here in the inferior panel, and the postoperative decompression at C5, C6. This is the second case. It's about a 53-year-old male with radicular symptoms regarding foraminal stenosis at C5, C6, and C67 on the right side. And after decompression, after performed foraminotomies with uniportal endoscopy, enough decompression is achieved. But remember, after planning your procedure, you represent your planning in your surgical event. And you have to recognize the bone landmarks, the anatomy, and then continue with the decompression. Here we recognize the B point. Here's the facet joint. You can see the SIP and inferior articular process. Sometimes if the procedure requires to get access to the axillary area of the nerve, sometimes it's required to decompress or remove the medial aspect of the pedicle, but just as the case required. The next procedures were done under biportal endoscopy. Biportal endoscopy uses two ports. The first port is, or the first channel is used for the endoscope. The second channel is used as a working portal, depending on the surgeon. The right side surgeon used with the left hand the endoscope, and with the right hand the surgical tools. But the difference between uniportal and biportal is that in the second procedure, you can use your surgical instruments independent from the endoscope. So you have versatility, and you can handling your surgical tools with more degree of freedom than the uniportal endoscopy. You have to create a working space above of the bone landmarks. In the epiperiosteal space, it's a space filled with fat and connective tissue, and it's not a great damage for the patient because there is only fat, and you don't detach any muscle because you are working medial to the multifidus muscle. Then the irrigation goes through the endoscope and exits through the working channel. This is the difference, cosmetic difference between uniportal and biportal. There is no big difference about both techniques, but some surgeons cannot do only uniportal because require more skills than biportal, or the learning curve are steeper in some uniportal procedures compared with biportal, or some orthopedists has more experience with the arthroscope, and they prefer starting with the learning curve in endoscopy in biportal procedures. It depends on the doctor. The patient position in biportal endoscopic procedures is similar to any other posterior cervical procedure. You can use more surgical tools in biportal because you can introduce independently from the endoscope your surgical tools. You can use different drills, RF probes, and endoscopes, etc. We have two major approaches for biportal endoscopy, the ipsilateral approach and the posterior inclinatory approach. Both has indications. For example, the ipsilateral approach, for example, has the major advantage is the feasibility to reach the target from the same side, and you can approach the facet joint as uniportal or as microforaminotomy. You have to remove more bone because your approach is perpendicular, and also you can decompress the exciting nerve. This approach is useful, for example, for performing ULBD procedures. You can observe here in the video how we decompress the lamina, the base of the spinous process, and this is a dural sac in a patient with spondylotic myelopathy, with cervical spondylotic myelopathy. So ipsilateral approach through biportal technique is a very good option to decompress the central spinal canal, as you can see in the video. But we have other option. The posterior cervical inclinatory approach is a medial to lateral approach. You're starting from the midline and you dot your both ports, but with this oblique trajectory. Especially is very useful, this approach, for which long trajectories of the exiting nerve. As you can see in the video, you can decompress long trajectories of the exiting nerve root compressed because of some anti-ventral vector of dorsal vector in the foraminal area. But the major advantage is you only undercutting the facet joint. Don't remove the facet joint because the medial oblique trajectory led to do that. It allowed that. This is another procedure. This is a central decompression through a ipsilateral approach in biportal technique. You can see the same steps that in microsurgery in uniportal are followed. You have to reach the attachment of the ligamentum flavum, and then you have to remove the ligamentum flavum. You use the over-the-top technique to avoid damage of the dura, and you finally can reach the complete decompression. This is an example of a 45-year-old female with severe radicular pain in the right arm, numbness in the dorsal surface of the hand, especially in the middle finger, with weakness of the right triceps. You can see in the preparative MRI, C6, C7, this lateral disherniation. That was the diagnosis with a C7 compressive radiculopathy in the right side. We choose a biportal technique for decompress this patient. We can other options as spinal surgeons, ACDF, TDR, etc. This is the approach, is a ipsilateral direct paraspinal approach. This is the video. The first thing is to recognize the bone landmarks. This is the B point. Here's the C6 lamina and C7 lamina, and you can start to decompression in the B point because this is the route to reach the exiting nerve. Then after that, you reach the exiting nerve. You can see the inflammation because of the discerniation process, and you can use microsurgical dissectors to remove the disc. This is different than uniportal because you have more degree of freedom with your right hand to mobilize and manipulate the neural elements or the epidural space. After complete removal of the discerniation, you can explore the neural elements. And here is the exiting C7 exiting nerve. Here is the thecal sac. So this is what you can achieve with biportal techniques. This is the postoperative MRI. You can see the discerniation in the right side, and here you can observe how we decompress completely the neural elements. This is the postoperative CT scan, and if you imagine if we perform big bone removals, it is not true. We have to plan in the surgery, and then we address specifically for one target point or endoscopy. This is another case about a patient with foraminal stenosis in both levels. We use an inclinatory approach to address the foraminal stenosis and decompress the patient. Well, as conclusion, water-based endoscopy, uniportal and biportal, is still an emerging minimal invasive option for symptomatic compressive radiculopathy and myelopathy of the cervical spine. The advantages include high quality target visualization and minimal collateral effect regarding tissue trauma, but the disadvantages include a steep learning curve, high cost for some systems, and the learning process. So we need more quality evidence with an appropriate methodology to support the water-based cervical endoscopies true potential and shortcomings, because until today, we have only outcomes from individual experiences. Thank you very much for your kind attention.
Thank you, Javier. I think you made very nicely your point and showed the potential of cervical endoscopy, and we can open now to discussion also from previous lectures. Please, people can ask for permission to talk, and please make very short questions in order to keep the flow.
Professor Oscar, how do you decide the indications whether to go for a arthroplasty or artificial disc versus minimal invasive spine surgery anterior posterior? What are the short indications for arthroplasty versus minimally invasive?
To whom are you addressing?
Gota, please introduce yourself and say to whom you like to direct your question.
I'm Dr. Uday Gupta. I want to ask to Professor Oscar. Sir, how do you decide whether to go for minimally invasive surgery or whether to put an artificial disc?
You mean in what situation? In what situation? Can you be more?
In a young patient, or an ACD patient, or a degenerative spine, what do you prefer? I mean, the indications for arthroplasty have definitely expanded. So how do you decide whether to put an artificial disc or whether you'll just do a minimally invasive discectomy?
Right. Okay. I mean, whenever you have a soft disc herniation in cervical spine causing radiculopathy or myelopathy, I think you need to take it out. You need to remove it. And if the patient is young, has minimal spondylosis, it's a good indication for cervical arthroplasty. And it doesn't matter the number of levels you are doing the surgery. You can do multiple level surgery. If you're dealing more with isolated foraminal stenosis, bone stenosis, you have the option of doing posterior foraminotomies or using this technique I show you, the posterior facet joint implant, where you can really increase the foraminal height, and this is sufficient to get rid of symptoms.
Thank you. Thank you.
Thank you, Gota. I think, Oscar, you have many questions over the panel.
Right. There is a question from Chaimov for Professor Schubert. And I think this question is related with patient selection. And I can add to the question is, when we listen to you, it seems that everything can be done through endoscopy. So we are not really talking about patient selection. But for beginners, for starters, what kind of selections of guidelines can you briefly recommend? Please, yes.
Okay, now you can hear me. Hmm?
Yes.
Yeah, okay. Yes, thank you very much for these questions. You know, I'm trained as a real spine surgeon in the German Spine Center. So I did everything. Okay, I did fusion, scoliosis, morbus Bechterew patients, everything, and everything we did was always with screws and rods. That's how I was trained and what I learned. And when I decided to leave the clinic, I thought I'm the biggest spine surgeon because I can put screws and rods, I can fix everything in cervical spine, to manage fractures. But there are a lot of degenerative disease you maybe see not in clinics, but if you're a normal spine doctor, not in a clinic, I have now my private clinic, you see different patients. And what I still see is that the indication for, let me say, fusions and artificial disc replacements, even if in the lumbar spine, the artificial disc replacement, it's not, they had a hype in 5-10 years ago, it's not that much anymore. I think we do too much of fusions. They're like you saw in with my overview with what is possible. Even in Germany, I think we are high developed. I see patients just with a disc herniation and they're coming to me, Dr. Schubert, I wanted to have a second opinion. They want to make a fusion and I found you in the internet and I saw your videos with endoscope. Can you do it like that? And I said, yes, you have just a disc herniation. Why they want to make a fusion? For what? And I started now 20 years ago in 2002. And I started with Thomas Hoagland. He is one of the pioneers beside Tony Young in Phoenix, Arizona. And I thought, come on, this keyhole surgery, endoscopic, what is this Dutch guy doing? And I was impressed because he operated patients I would have operated in general anesthesia with the, even if the cut is only 3-4 centimeters in lumbar spine, resection of muscles, taking bone, open the ligamentum flavum, all the still worldwide conventional procedure, and he did it with the endoscope. I thought it's not true. So the patients, they stand up one hour after the procedure and they hugged Mr. Hookland and said, Dr. Hookland, I'm so happy I have no more pain. And then I start to also to change my view, my side to my view to patients, and I decided to learn this technique. And when I learned this technique, I thought, this will be the gold standard in maybe 4 or 5 years. It is 20 years ago, 20 years, what we are doing. And why not more people are doing endoscopic procedures is because I think the instruments are expensive. It is very complicated. The reimbursement mainly in not rich countries like India, Pakistan, 2 years ago I was in India. In China is different. They have money like nothing, okay? They have everything. They have the best equipment. But in many countries, it is too expensive. And this was the reason that I started with the septovation instruments, because less of instruments, much cheaper. They're reusable, they're not disposables. And because with disposables, the procedure you make also expensive. And I trained, I think, more than 500-600 doctors. And with this presentation I gave to you, it is much more easier to learn. In the beginning, to come back to your question, I would start with an easy big disc herniation. Okay, maybe level 4, 5. You have not the iliac crest in maybe in the lateral view, what is maybe disturbing you. So I would start with that. And if you get familiar with this kind of procedure, you will try to do more and more things. I hope
Thank you. Thank you, Michael. Actually, we are amazed by the number of patients you operated, 10,000 patients by endoscopy, and by your results as well. Thank you very much. Oscar, do you have more questions?
Yes, there is a question here for Javier, and it was also my question. Because Javier, in 2 weeks, I will be doing my first cervical cases. So I was paying a lot of attention to your talk. And you know, I think cervical compared with lumbar, the topic of the fluid pumping is very different.
Yeah. Okay.
So what kind of advices can you give on that? Because lumbar spine is much more forgiving in terms of you know, speed of pressure of infusion, but coming to spinal cord, to cervical spine, could be a problem. And this is also a question that I share with Min Seung Jeong, I think from South Korea, and he addresses these concerns. Do you have any tips?
Yeah, of course. You know, for any spinal endoscopic procedure, the increase of hydrostatic pressure or epidural pressure is a concern. But for example, in cervical spine, it's not a big difference compared with uniportal in that terms, not in the pressure in that terms. You have some options to control the bleeding, and the hydrostatic pressure can start a little bit lower than lumbar spine. You can start with 20 millimeters of mercury, or if you have a pump water pressure. If you're using a pump water pressure, you can set the initial pressure at 20 millimeters, 15 millimeters, and then increase as your procedure required in terms of bleeding. But remember that we have to remember that solution, the fluid, has some advantage. The first is to preserve cleaning the surgical field. The second one is to observe the exactly source of the bleeding and then make some measures to control the bleeding. And the third thing is to avoid damage of the neural elements, because we can perform hydrostatic dissection when we perform the phlebectomy and push down the thecal sac or the dural sac to avoid any damage. So we don't require high hydrostatic pressures to reach that goal. In cervical spine, I use, for example, I don't use pump pressures. I use gravity, and I put my back above the patient 30 centimeters, that is equally to 30 centimeters of water. So I use that kind of tip for my hydrostatic pressure and my continuous fluid during my surgeries. In lumbar spine, you can increase your hydrostatic pressure until 60, 70, or Professor Tony Young said, use 100 centimeters of water and there is no problem. But it depends of the expert. I think it's not a big problem if you perform your procedure step by step always, and take advantage of any feature of endoscopy. Fluid is to recognize bleeding, control bleeding, dissect the neural elements, and that's all, and cleaning the surgical fluid.
Thank you.
Thank you. Thank you. Maybe we take one more question and then we proceed to the second session because we are 30 minutes far behind our schedule and we still have 5 more speakers.
Nasser, I really don't see any new question and answers here. So if you don't mind, we
Jyoti, did you like to say any comments before we proceed to the next session? Jyoti, can you hear me?
Yeah, Nasser. No, okay. I'm very happy about whatever we have discussed.
Okay,
fine.
Okay, thank you very much. Now we proceed to the second session. Would you introduce our first speaker, Oscar, please?
So our next speaker it comes from southern Brazil. Is another friend, Geronimo Milano. Geronimo is director of the spine division of the Neurological Institute of Curitiba. Is chairman of AO Spine Brazil, and also director of the spine department of the Brazilian Neurosurgical Society, which is probably in number of members the second world society. So Geronimo, you will show us the anterolateral approaches to lumbar degenerative spine. Thank you, Geronimo.
Oh, thank you very much. I'm going to share my screen. Is that all right? Can you hear me and can you see my screen?
Yes, good.
Okay, so thank you once again for the invitation. I'm going to talk about the anterolateral approaches for lumbar degenerative spines. These are my disclosure. And we're going to define some general concepts. We're going to talk a little about surgical techniques and talk about the advantages and limitations we have with this procedure, and especially when and why to do this kind of procedure. So it's never too much to repeat, as we have some young surgeons here, that most of lumbar degenerative cases do not need surgery at all. This is the most important topic, because also we start to do minimally invasive surgery. It seems that we can do surgeries without any problem. This is not true at all, okay? And the second point, it was said by some of previous speakers, is that most surgical lumbar degenerative cases do not need fusion, okay? So this is totally proved by some papers we have in the next 10 years. But if you need a fusion, then you need to take a look at the biology, and you need to take a look at alignment. And for sure, the best option when you think about alignment is thinking about the Wolff's Law, which says that once you have compression in your graft, you probably are going to fuse. You're probably going to have bone ingrowth. And that's why we need so many options for interbody fusions. This is a paper published in the recent years that showed the amount of options we have to do an interbody fusion. So if you take a look at this image and you draw a line through the transverse processes, everything you do anterior to the transverse process line is what we call anterior or anterolateral approaches. What are the advantages of going anterior? The first is, of course, you don't have any nerve root manipulation. You don't have any muscle damage, okay? This is the most important point. The second is that you can put a larger cage, and if you put a larger cage with a bigger amount of bone graft, then you have a higher fusion rate. You're going to resect more disc. It's less invasive since you will not damage the posterior muscles. You would have less bleeding. And one of the most important points is that you can achieve a better sagittal alignment. Yeah, most of posterior procedures are actually a kyphotic procedure. And maybe with a better sagittal alignment, maybe we have less adjacent segment degeneration. So I'm going to start talking a little bit about the ALIF. This is the classic publication made by Salvador Brown. Here he described the type of incision we can make. We almost always goes through the left side. The only exception is we are doing single L5S1 in men because theoretically there is a smaller risk of retrograde ejaculation. This is the position. We can put some support below the knee, only to make the vein a little softer. And I prefer to do an X-ray just to see what is the perfect angle I'm going to approach the disc, just like this. The classical procedure includes a 360 dissection of the rectus abdominalis muscle. I don't do this anymore. We do just a medial incision of the fascia, and then the dissection with a finger through the retroperitoneal space, and then we retract the retroperitoneal space, all the peritoneal content, until you see the psoas muscle. You can see the ureter here. It's quite easy to dissect and to retract gently the peritoneal sac. In most cases in L5S1, we're going to deal with the bifurcation of we're going to work below the bifurcation, so it's easy to dissect the iliac vessels, and then we're going to find the sacral and medial sacral vein and artery, which you need to coagulate. Then we resect all the disc. We can put a bigger cage with a big amount of bone and put some screws in order to have immediate stabilization. In L4, L5, probably you're gonna deal with the bifurcation. I don't use angio CT for that. I can see easily the vessels anterior to the spine and know where is the bifurcation. In most cases, we're gonna retract the aorta and the vena cava, but it's important to find the iliolumbar vein, cut with ligation or coagulation of this vein, because otherwise you're not have space to see all the disc from anterior like this, and it's very dangerous to rupture this vein. Then you can have some vascular problem, a lot of bleeding. It is very difficult to repair. This is how we see the L4, L5 disc. And in this X-ray, you can see both discs replaced by a cage with screws. The other option is go from lateral. There are two different options. One goes anterior to the psoas, and the other ones go through the psoas. The first one was described by Michael Myers 25 years ago, It's an option to the ALIF. And then Dr. Pimenta, with some friends from California, described the trans-psoas approach. The concept is quite the same. We're going to put a larger cage, which is going to be positioned all the space laterally from one cortical to other, in order to have a indirect decompression by stretching the yellow ligament, by realigning the spine and increasing the disc height. So as you can see, we can have a very nice indirect decompression without any posterior manipulation in most cases. And this has been proven clinically and radiologically, but with the two approaches. Here is the anterior tube psoas, here is the trans-psoas. You can have a very nice indirect decompression in most cases. The advantage of going anterior to psoas is that you don't need nerve monitoring. You will never have, almost never have nerve damage. There is less psoas muscle damage, but the advantage is that it's very difficult to do from the right side. So if the concavity of the curve in a coronal deformity is in the right side, it's very difficult to correct adequately. And up to 20% of the cases, there is no window in L4, L5 to go anterior to psoas. The advantages of going through the psoas is that you maybe have a more aggressive correction. You can do it from both sides, but the truth is that you need much more radiation if you don't have navigation, and you need nerve monitoring, and there is an increased risk of nerve damage at L4, L5. When you take a look at the literature, there is a big variation between the rates of neurological symptoms, even transient, but it's very common to have some nerve disturbance after a trans-psoas approach, which is more risk when you're dealing with L4, L5, especially at the right side. There are some differences in the position. I'm not going to talk about the ALIF since Dr. Pimenta will have a speech about doing the ALIF trans-psoas in the prone position. So we're very anxious to see what he's going to talk about this. It's a very disruptive idea. I think everyone is going to like to see that. So we do the anterior tube psoas in the lateral position. There is no big bending in the table. Always do an X-ray to see where we are, and look that the incision is not at the middle of the disc. It's projectly a little anterior to the anterior portion of the spine. Here is the dissection of the three muscles we have in the abdominal wall. And after opening the transverse abdomen, we're going to find the retroperitoneal fat. We're going to dissect this and then find the psoas muscle. Gently retract the psoas muscle, just to take a look where we are in the anterior anteroposterior portion of the disc. You can put some retractor. There are lots of retractors in the market. And then we're going to remove the disc and do this orthogonal maneuver in order to put the cage as perpendicular as you can in order to have a good reduction and indirect decompression. You can do even 3 levels with the same incision. This is how the scar is at the moment, and this is after the closure. This is the cage. We have 3 discs replaced by cages with a good correction in both coronal and sagittal planes. This is the patient 1 day later. And now we're going to talk a little about when to choose ALIF or LIF. The first point is the level we're going to deal with. So there's no way of going transpsoas lateral in L5S1. So L5S1 is an indication for an ALIF exclusively. This is one case, a patient with lytic spondylolisthesis. As you can see, we can increase the disc height and do a fixation only for anterior. This patient was a jiu-jitsu fighter. He came back to fight 6 months after the surgery. This is another case, a patient with only degenerative process, but very symptomatic, severe pain, 2 epidural blocks, 3 facet blocks. As you can see, there is a lot of modic changes. This is probably the only indication of for a fusion in a patient with only low back pain. In this case, we use the previous incision she had at the for abdominoplasty, and now you can see how we increase the disc height and do the fixation only for anterior. This is one of the best indications for anterior approaches. Is a patient which has only a lumbar disc herniation here, probably a case for a microdiscectomy or even endoscopy. But what she got was a 2-level PLIF. One of the cases was inside the canal with clear pseudoarthrosis, severe pain. And now you can see the disc removed. You can see how the cage was mobilized. It was there was a lot of disc remaining in the disc space, and then we did a fusion and correcting the pseudoarthrosis. This is a very old case. At that time, we still were doing discography. A patient with 2 symptomatic discs. It's just to show that when we have L4, L5, and L5S1, we prefer to do both levels from anterior. When we are up in the lumbar spine, I mean L3, L4, L2, L3, we prefer to do the lateral. And this is one of the most important indications in my point of view. When you have adjacent segment degeneration like this, a patient who had a hypolordotic PLIF 8 years ago with degeneration of the 2 discs above, we can treat this patient only from an anterior anterolateral procedure. Another good indication, a patient with coronal deformity. As we can see, there is a mismatch between the lumbar lordosis and the pelvic incidence, as well as a coronal deformity. Disc degeneration, most in L2, L3, and L3, L4. And this is what we did. First, coming from lateral, 2 levels of ATP, correction of the imbalance. And after we have the clear correction of the imbalance, we just put the screws posteriorly for additional fixation. This is another case, a patient with 3 previous surgeries, small screws, pseudoarthrosis in L5S1, pseudoarthrosis in L3, L4, hyperlordotic discs in the above segments, trying to compensate the spinal pelvic imbalance. This is the MRI. There is no huge compression. This is what we did. ALIF in L5S1 and ATP in L2, L3, and L3, L4, opening the ALL and posterior instrumentation in prone position. This is the result we achieve in these cases. And the last case I'm going to show you is that we have the option of using expandable cages. This is one of our vascular surgeons. He has several pain from more than 20 years, but 2 years with neurogenical claudications. unable to stand more than 40 minutes, so impossible to work for him. This is the kind of cage we can use. You put the cage in very small fashion, and then we're going to increase the disc height and the angle of the cage progressively. This is the result we can achieve, and then do posterior percutaneous fixation. I think this is a very interesting and useful tool, but it's dangerous as well, because you need to take additional care in not damaging the end plate and going to the opposite side, because otherwise, when you try to expand the cage, the cage is going to subside immediately. Of course, there are some limitations. This is a review showing that some patients will need a second procedure, but it's much less than people frequently think. For an A-lift, for example, most people are worried about the need of a posterior fixation. The truth is that this is the overall rate of reoperation, and most of cases in the same level are not for stabilization, are actually for a residual or recurrent stenosis. This is another paper from Juan Uribe, which shows that patients with low BMI, pre-op listhesis, and disc collapses have a very high successful rate of indirect decompression. On the other hand, patients with preserved disc height and severe stenosis are more prone to failure. Roger published this paper some months ago, which shows that the most important individual radiological finding that increase the risk of having failure in the indirect decompressions is when we have a lateral recessive stenosis, mainly when we have a bony lateral stenosis. So this is the patients in which you will probably need a posterior approach alone or together with a anterolateral approach. So this is my conclusions. The anterolateral approaches are less invasive. You can achieve a higher risk, higher fusion rates when comparing to posterior, and you have better alignment. It's an excellent option for reoperations, either on the same or the adjacent level. We use A-lift for L5S1 or L4-L5, and the lateral through or anterior to psoas when you're dealing with L3, L4, and L4, L5. And of course, there are some limitations as I show you. Thank you.
Thank you, Geronimo. Wonderful presentation as always, very comprehensive, very didactic. I think we need to move to the next speaker. And Geronimo, please keep for the answers at the end. So we have a little change in sequence here. And our next speaker is Gregory Mundis from San Diego. I profile pediatric and adult deformity spine surgeon from San Diego Center for Spinal Disorders. He will talk us about how to push the indications of MIS surgery and address the problems of adult spine deformity correction. Please, Gregory, go ahead.
Awesome, and hope everyone can see the screen okay.
Yes.
Good. All right, here are my disclosures. First of all, thanks for having me. What a great webinar it's been so far, and appreciate all the speakers and everyone that's been on this webinar. Great interaction and very impressive group of people that have joined. So happy to be here with you guys, and thank you so much for the honor of participating. So there's a couple of basic principles I always love to talk about. One is everyone's always wondering about, the use of minimally invasive techniques and whether it's minimally invasive screws or their interbodies. But I always say that the metal, the screw or the cage does not have an IQ, but the surgeon does. So it's really important that we use our own brains as we try to execute the surgeries that we're looking to execute. And then the second is that, you know, when you look at data, we always have to be a little bit careful because not all patients are created and not all surgeons are created equal. And what I mean by that is, you know, a lot of the data that's reported on interbody techniques, et cetera, is based on what the surgeon needed at the time. So if you see like average degrees of lordosis for a T-lift versus versus a lateral or an A-lift, you know, you'll see these numbers averaged, but we have to always remember that we're treating individual patients, and sometimes you don't need a lot of lordosis and sometimes you need a lot. So again, take a lot of our data with a grain of salt, but that being said, those are sort of the basic principles. Other things with patients is that flexibility is key. And we'll talk a little bit more about that in this talk. The interbody technique, how you do it matters, and then your positioning matters. And it's really important that we don't go away from these very basic principles that actually happen even before we make a skin incision. Your experience matters, and so it's very important to be a part of these webinars. It's important to see other surgeons operate. I still love doing that, and it's important to then also understand the alignment goals that you have for your patients when it comes to deformity, and then what you personally as a surgeon can sort of recreate in that setting. So, real important that we use those foundational principles as we go through this talk. I know we've touched on this already earlier on in the webinar, but planning is critical. I think it's really important to get to know your patient radiographically. Once you've made the indication for surgery, and thank you, by the way, for saying that not all degenerative spines need surgery, and I would 100% echo that in the world of deformity. You know, the amount of patients I say no to pales comparison to the number of patients we say yes to. So it's the indication even for deformity is not huge. But that's a whole different talk. But once you indicate the patient for surgery, you know, take time and measure all the key parameters. This is sort of like how you're going to get to know your patient, you know, as you're three-dimensionally thinking through the surgery. And it's really important that you get to know your patient that way. You have to quantify the need for both sagittal and coronal realignment, and then you have to evaluate what options you have available to you, the fixation options, which osteotomies you might need, the biologics you're going to have to use, and obviously executing that plan is then critical. So when it comes to minimally invasive spine surgery, there's sort of 5 basic principles that we follow, and one is that the disc space is the working channel where we do so much of our correction. That flexibility is critical to achieving a good reduction of the deformity, and then that fusion is the ultimate goal, so we can't neglect it. And then anterior correction with posterior stabilization as the hallmark for when we do our ultimate deformity correction. I'm not going to belabor this too long, but just to say that it's important that we stay consistent in how you think about your patients before surgery. We have parameters that are in place that we don't operate on patients if they don't meet these parameters. All our cases, even when minimally invasive, are presented in front of a committee that then helps us make a decision whether or not the surgeries are appropriate or not. So again, the disc space is your friend. So we do a ton of work through the disc space. It's our workhorse. The disc space is where we get our correction, both sagittally and coronally. It's also where we end up getting the fusion. And so it's important that you assess the quality of your disc space. If there's error in the disc space, as many of you have heard us talk about this, we love error in the disc space because it tells us that there's some movement that's happening there. That error is generated from the degeneration in the bones rubbing against one another. And so that's important to see. It's also good to get these CT scans because you can evaluate previous surgery. And you may have to make alterations to your surgical plan based on what surgery was done. And then you also want to evaluate the ankylosis that can exist in these patients. Certainly if ankylosis exists, then you may have to change how you consider doing the surgery. And I think Juan Uribe talks about going posterior, then anterior, then posterior, and there's other ways to get around it. But I just realized there are sometimes those limitations are really important to know before you do the lateral interbodies. So the second principle, if it's flexible, it's an MIS candidate. And so it's important that you assess different kinds of flexibility, both the regional flexibility. So in other words, how much do the segments move relative to one another? Their global flexibility, which you oftentimes can tell from a supine X-ray to see if their global alignment changes. There's intraoperative flexibility. Once you're under anesthesia, how does the lumbar spine and the thoracic spine change? And then we have to realize that each of these patients is a little bit different, and we have to really evaluate them independently. Here's just an example of taking a patient that goes from standing to supine. You can see the disc spaces open up between the two, which shows me that there is some inherent flexibility between the two. He does have kissing spinous processes posteriorly, so I know there's some limitation just secondary to the collapse of that individual level. And here you see supine, again, some flexibility and coronal alignment. This is just an example of what we do in the operating room to assess flexibility. We will take a long 36-inch cassette to try to understand the overall alignment of the patient, even in the operating room, to then assess what needs to be done as it relates to the surgical plan. So here's what she looks like after the anterior portion of the surgery, and we'll come back to this case a little bit later. But if we were to take her standing scoliosis X-ray and flip it on its side, it would look like this. So you can see that the angular changes that occurred between T4 and the sacrum certainly are in a much favorable position at this point. So the next talk about a little bit is fusion as the workhorse. It's important to evaluate this. You know, there's a lot of new implant technology now that's actually been pretty beneficial, I think. We're publishing our series right now on 160 patients that had these interbodies, these 3D printed interbodies that have a titanium infrastructure that's more similar to the cancellous bone. And we're finding that fusion actually is taking on at a much higher rate, which seems to be pretty awesome. I would also say that in relation to fusion, don't be afraid to, as you're using new technology, to image your patients down the road. Yeah, oftentimes even that 1 year, just getting into a CT to understand, I think is a good idea. And next is that the anterior column is really our workhorse. So for understanding that, you really have to start measuring parameters that are going to be helpful for you in executing a plan. And so again, measuring things out, understanding where the patient is in space, and then what you can achieve radiographically, intraoperatively, I think is really important. So having your alignment goals is critical as you work your way through doing and executing this plan. And so again, the anterior column is our workhorse. In this case, we're lacking lordosis regionally, and so we try to restore the L4 to S1 as much as possible. So we put in a hyperlordotic implant at L5 S1 to make up for the flattening between 4 and 5, and then place numerous interbodies above that. And the idea here is that we're trying to recreate a harmonious curvature in the lumbar spine. And so if we evaluate our implants, this is in between stages here, you can see what's been able to be achieved from a sagittal alignment perspective. We went from 29 degrees to about 57 degrees, which put us right on mark for where we wanted to be for our patient. So you also have to include which levels. So you also have to understand which levels you want to include for the fusion. And so for this, I do think it's important to understand the deformity principles. I always use a plumb line to understand what will intersect from the top down and the bottom up. I use a CSV a little bit more often, where I go from the center of the sacrum north to try to see if there's a balanced way to correct the spine. And you have to, in my opinion, always include the Cobb levels in the fusion. I think it's for sure a mistake to go into the apex of the curve, so I would never fuse into the apex. I do think there is for sure a role in just fusing the fractional curve in some patients rather than doing the entire deformity. But again, it's a whole nother talk. But the Cobb levels, I think, always need to be included. Don't leave potentially unstable discs unfused. And so you have to assess your patients pretty well, and that's including mobility x-rays as well as understanding your CTs and MRIs. And so this involves both applying the degenerative principles as well as deformity principles and determining your UIB and LIB. And then how you get your coronal correction also matters. Typically, this is happening with multi-level lateral interbodies. For me, I like to use slightly smaller implants. And so if it's a choice between like an 8mm and a 10mm height implant, I'll typically choose the 8, especially as I'm doing this at multiple segments. I feel if you overstuff the anterior column, bad things can happen. More importantly, I think it's a lot more difficult to correct it posteriorly. So I think leaving a little bit of wiggle room in the anterior column is good. And then finally, you got to pay critical attention to your fractional curve. If you don't fix the fractional curve, you'll be in trouble. I also use the BAL classification. It's simple, it's easy to use. Just to say that BAL type C curves have to have an aggressive fractional curve correction. If you can't do it, then do it open. Because the BAL Cs are the ones that we see are very frequently worse off after surgery because we have a difficult time restoring the lumbosacral curve. From the sagittal plane, certain experience matters in this group because there's many ways to get anterior correction from, lordotic corrections, angular corrections from the anterior column. It's just you have to be experienced with it. So whether it's doing an ALIF ACR where you're putting a hypolordotic implant and doing a really wide dissection around the disc space, or doing that from the lateral, doing minimally invasive PSOs. I mean, there's different ways to achieve that. Some of it just depends on the experience that you have with it. Certainly ALIF is a great workhorse. You can see here, again, 1 degree of lordosis, you put in a 30-degree implant, sorry, a 20-degree implant, and you get about that out of it. So here's another case of a 79-year-old female with the previous fusion from L4 to S1, and on her we did just multi-level interbodies above above her fusion, and then fixed her up into the lower thoracic spine. All this done percutaneously, and having a very, very nice durable result now at 2 years. Again, looking at this principle of anterior correction, this is an anterior column realignment procedure where we do get hyperordotic implants in through one disc space. This is akin a little bit more to like a PSO, where you can get a lot of correction through a single disc space. There are its complications associated with it, so just be careful when employing this type of procedure, but it can have a pretty dramatic effect on these patients. This is a patient that's had a previous T10 to pelvis. He had an L3-4 TLIF that went on to a non-union, and then what looks like more like a Charcot spine. This patient, we just went in open at the very bottom. We did a, you can call it whatever you want, an MIS PSO or just a PSO. Bottom line is we didn't open the entire incision. We just opened the part where we needed to do the osteotomy. We also ended up doing an ACR at the level of the TLIF that had gone on to a pseudoarthrosis. And so there we went in lateral, took the TLIF out, cut the ALL, got the correction there, and then went from the back and did a PSO because the patient needed a dramatic amount of correction. Screws are like a rebar in a building, so they provide the structural support for the inner bodies to heal. So I am not an aggressive posterior facet fuser. I much rather get the fusion anteriorly. Certainly, if I don't have an inner body in the disc space, then I will fuse the facet joints. And I typically use just a little bit of off-label BMP for that. This is just showing that it's very simple to actually measure these parameters out. This is using the surgeon map. And you can see that to measure the sagittal parameters, even in the office, just takes a screenshot. And then probably somewhere, I think this video is like maybe 20 seconds. It doesn't take very much time at all to get your parameters very quickly for you to at least make a preliminary assessment of what you want to do. So you want to get global, regional, and segmental alignment. These are our goals as the surgeon and our responsibility when we execute these. Sometimes we can't do it MIS and we have to go open. This is some of our early data that basically ended up saying that we're not very good at MIS deformity surgery. Mild deformities were okay, but hybrid approaches where we went lateral and open posterior seemed to get the most correction when it came to PILL. And then just looking back at the years of all the different papers that were shown, we just have sort of a limitation in how much lordosis that could be achieved. And then basically we went on to relook at some more data through the ISSG and found that similar issues, which is if we had patients that had low or mid PIs, we did okay. But as soon as we had patients with high pelvic incidence, when we fused them, we actually created flat back deformities, fixed flat back deformities. So it's definitely an evolving frontier. We know that these are all these papers that are studies published on what you can achieve with recreating lumbar lordosis, but they don't ever really talk about what the intention was. And so it's hard to determine what actually is, how much lordosis you can actually achieve. And if you need more, like we said, you can always use things like the anterior column realignment procedure. So this is looking at a prospective portion of the MIS, portion of the ISSG, where we now are at a whole different phase of our learning curve. And now you can see that we actually are doing a lot better in treating patients that have more severe deformities. And if you basically take patients and break them down by their most severe deformities, these are patients that had pretty big differences in their PILL. You can see that we had a very nice correction in their in the restoration of their mismatch, and getting a lot more correction as we needed it. And you can see here again the lordosis that we were able to generate, and then part of that had to do with advancement in techniques, and about 42% of these having ACRs. So can we provide a good environment for deformity correction? I think the answer is yes. For severe deformity, I think it still remains to be a question. And I know just as surgeons, we have to know our own limitations and then be able to execute a plan that we determine for our patients. So with that, I'll stop there, and thank you very much for having me, and hopefully that was educational.
Thank you, Gregory. Very, very clear lecture. So I know we have family issues. I just can ask you a very quick question.
Sure, please. Love it.
You still consider there is a ceiling of correction with MIS, even with the new technologies, expandable caging and stuff like that. You still have a ceiling that you cannot correct.
Correct. Yeah. Well, there is. I think where we're finding our biggest problems are in not problems. I think what we're finding is that in patients with unfused spines, I believe our ability to correct that patient is very good. Where we're finding our limitations now is in the revision world, where patients have flat backs, where they have previous fusions that have left patients in a position where it's difficult to restore the appropriate relationships that the lordosis requires for us to have people sagittally aligned. And so, what for instance, what we classically did would be putting hyperlordotic cages higher up on the lumbar spine, but we were just creating PJK like crazy, like adjacent segment disease and PJK. So then it's like, all right, we need to get more of the correction at the bottom. And so this very much is drive towards ALIF and lateral for restoration of lordosis. I think that's happening all around the world. I think it's a good thing. But I think the thoughtfulness, I think the execution of revision cases in deformity setting is very, very challenging, because we're very limited in what we can do, because we need that interbody space to do our work.
Okay. Thank you, Gregory. Thank you. Enjoy your day. Thank you.
All right. Thank you, guys. Appreciate it.
Thank you. Bye-bye.
All right. Have a blessed day.
Next, we move to Professor Ali Baj. He's Chief of Spine Surgery, Associate Professor of Neurological and Orthopedic Surgery, University of Arizona, College of Medicine. Ali is really an excellent communicator, and I really thank him for being so patient and allowed to change the sequence of presentations. Ali, please tell us about enabling technologies for MIS surgery in spine. Okay, I think we need to, there is a little delay here. We need to move on next presentation. And while Ali is doing a little word round, so in Arizona, it's really difficult to articulate different time zones. So we probably need to move to the next speaker. Let me see who is around. Dr. Pimenta, are you around? Not really? No?
Yeah, I am.
Okay, dear friend.
Yeah. Well,
can you share your screen with us?
Yeah, let me see if I can share my screen. That's my problem right now.
Okay.
So early time here.
You have share screen or compartilhar tela.
No, but which one? Dropbox?
No,
which one?
Compartilhar tela.
No.
Just click there.
That's fine. What's the recent talk? Where's my talk here? Share screen, which is my.
You open your presentation in your desktop first, and then screen share.
Yeah, let's see where's I did this before, so I know which one is. So what about you call somebody else before, and then I will train on.
I'm good to go. I'm good to go, Oscar.
You are there, Dom? Thank you.
Yeah, I'm here. I'm good to go.
Okay, Dom. So you're always precious. So Dom is certainly a core figure in the world of cervical spine. Is chair of WNS-CNS Joint Section of Spine Disorders. Is president of the International Society for Advancement of Spine Surgery, professor of Department of Orthopedics, Atrium Healthcare in Carolina. Is certainly one of the biggest names in cervical arthroplasty as well. But his lecture today is on MIS transpedicular screws, cervical screws. Please, Dom, go ahead.
Thank you for the kind introduction. Do you see my screen, Oscar?
Yeah. Can you put it in full screen mode?
Okay, let me see if I can do that.
Just come down next to the loop on the bottom.
Okay.
You see on the upper part where you have display setting.
Yeah.
Like on the a little bit on the right, display setting. Click there.
Here, more.
And you should have like swap.
Let's see this. Let me try the. Sorry to. I can get this one going for us. I think here it is. Display settings. Okay, let's do this.
Just on the small arrow.
Okay.
Yeah.
Yep.
Perfect.
That one.
Perfect.
There we go. Is that working?
Perfect.
Okay. Thanks, guys. Thanks for putting on a great symposium, and thanks for involving me. I know we're running behind, so I'll get right to it. But Oscar, always a pleasure. This is my disclosure. This is our group in Charlotte, North Carolina. We have upwards of 40 neurosurgeons, so I think we have the biggest group in the U.S. And what we're going to talk today about is some transpedicular fixation options in the cervical spine. So we know with posterior cervical fixation that the traditional approaches are associated with significant morbidity related to paraspinous muscle denervation, atrophy, and disruption of the musculoskeletal complex. We know that, and that's one of the emphasis of this symposium has been minimally invasive. So we all, I think, understand the advantages of less muscle disruption and less invasive approach. But having said that, this is certainly one of the more invasive procedures that we have when we have these long segment fixations that we have to do. Furthermore, pedicle screw fixation has become the standard of care for thoracolumbar fixation, but not in the cervical spine, even though there are several studies that have demonstrated the feasibility of pedicle screw fixation. And this really dates back to the 90s when Abumi described his open technique for cervical pedicle screw fixation in the entire subaxial spine. So this is certainly something that's been elucidated over the years, but has not ever been adopted to a real minimally invasive approach. As far as the biomechanics go, there's no question that pedicle screws provide the single most powerful fixation in the subaxial spine. Compared to lateral mass fixation, we're looking at anywhere from 4 to 6 times the pull-out strength. We're talking about longer screws that are angulated, triangulated in medial trajectory. We're talking about larger diameter screws as opposed to the standard lateral mass screw fixation. So it's anywhere from 4 to 6 times pullout strength and nearly a factor of 10 if you add in those other biomechanical considerations. So there's no question that it's stronger. So the question is, if it's so great, then why aren't people doing it? Why isn't there cervical pedicle screw fixation a common thing? I think standard of care has become fixation at the end of a construct at T1 and T2 and maybe C7, but we're not seeing typical subaxial pedicle screw fixation. And the reason is technically challenging. This is relatively small pedicles. The lateral to medial angulation can be significant, especially if you're trying to do it open with the midline incision. Some of the angles are almost impossible. Like I look back at how Abumi had described it initially in the 90s and early 2000s, and I marvel that he was able to do the kind of fixation he was able to do because those angles are so difficult. And then, of course, as we all know, in the cervical spine, there is great proximity of very important structures, neurovascular, spinal cord, vertebral artery, and the nerves. Having said all that, there have been improvements in intraoperative navigation and instrumentation. That's really what we're talking about, that have made this really biomechanically robust procedure, which is technically challenging, into a very feasible MIS percutaneous procedure.
Dom, sorry to interrupt you, but your slides are not progressing. You're still in the sliding introduction slide.
Let me see.
Are you moving forwards or?
Let me see. Yeah, I thought I was progressing. On my screen, they are.
Not here. You're still in.
Okay, let me.
Slide.
Let's see if we can. Let's see if I can fix that. Sorry about the technical difficulty. I'll come back and I'll try to screen share again.
We may probably, do you think we could progress with another? Yes, okay.
And then let's see if we can.
Remote.
Let's do the slideshow. Let's see if we can do this. Are you seeing it now?
Yes, but that's acceptable. Okay.
It's still the other setting though, right?
Yeah, but
it's okay. Good. It's good. Okay.
How is that?
Yeah, perfect.
Excellent. Excellent.
Okay. So this is what we talk about, the open fixation, and we talked about the morbidity associated with lateral mass, as well as the biomechanical stability associated with pedicle screw fixations. And we see over here the triangulation of the screws, the larger diameter screws, the larger length screws compared to the lateral mass. We talk about how it's technically challenging, and then that puts us here. Are we okay, Oscar? Can we see everything?
Perfect. That's perfect.
Right. So what navigated percutaneous pedicle screw fixation does is it circumvents the drawbacks associated with the open pedicle screw fixation that we were talking about, while at the same time providing this incredibly robust fixation. This is a muscle splitting technique, so it's not necessarily incision size, but it's the fact that you're not pulling the muscle off of the bone, as we all know, and you don't see the atrophy and the denervation of the musculo-ligamentous complex. The trajectory, the lateral to medial trajectory, also makes it much easier to put in larger diameter and longer screws. This is our first series, which was a series that we really published last year, was a preliminary series to just talk about the proof of concept that this is something that could be done. We did it extensively in the cadaver. John Pelosa and I early on as part of the team, and then some of my other partners, Paul Kim and Tim Adamson and Vince Rossi. But we're using these kinds of screws with the extended tabs. Here's from that article that was published in IJSS last year. We had a total of 27 patients. The indications were, as you see here, multiple subaxial, also C1, C2 indications. As far as our complication rate, we did have one screw that was revised intraoperatively without a problem. Two patients required reoperation, one for reposition of a screw and one for a body fracture. So I'm going to go right into some of these. It's easier for me to show it to you than it is to talk about it, but we do have a series that talks about a evidence basis for this and proof of concept. And we are currently undergoing a prospective protocol to look at these, to look at a larger series. This first patient is a 69-year-old who was involved in a motor vehicle collision, C6-7 fracture dislocation. You could see a fairly dramatic fracture here, dislocation, spinal cord injury. One of my partners actually did this anterior procedure and put in a spacer and an anterior plate. Given this ligamentous disruption and this dramatic injury, our concern was that this was not enough to hold the patient. So we brought him back for extra fixation. And as the surgeons all know, that this, if doing it posteriorly, especially in the trauma population, there's a high infection rate. People who are quadriplegic have a high rate of wound breakdown. They're laying on those wounds and they're remaining in collars, which is problematic. And so this could be a very morbid operation in this patient population. So this is actually the first case that we did with this technique. So we position prone with a Mayfield on a Jackson table. You have to prep extra wide because the trajectory is very lateral to medial. You can see the first thing we do before we even do anything is make a small skin incision and put the reference frame and the fiducial on, and then we immediately obtain a O-arm imaging. And so before any incision is made or any other planning is made, then here I am with Vince Rossi, one of my fellows who's currently doing fellowship, a spine fellowship in Australia. This is we plan the entry points after we get the O-arm imaging. And then you can see here, we're looking at the image, we're looking at the screens, not actually at the patient. And you can see the very lateral incisions, percutaneous incisions that are made. Unlike thoracolumbar spine, it doesn't make sense to make separate stab incisions because they're so close together. So we make one skin incision, but several fascial incisions. So it really is muscle sparing. And then with guidance, navigated guidance, you drill your pilot hole and then use the power tap to tap through the hole. And you can see the process right here of putting in power drilling and then putting in the screw. You can see we're looking at the frame here. My side is already done. The screws are in with their towers. Here's Vince is putting his side in and passing the rod percutaneously. And just like a thoracolumbar, it's a percutaneous pass. And then here we are with tightening the screws, with the screws on one side and tightening on the other side. Here's the closure is just with Dermabond. There's no collar used post-operatively. Patient is not laying on that large wound. There's very little muscle denervation. Here's the final pedicle screw fixation, where typically you might, with lateral mass screws, look to go longer segment because of the inferior fixation. You might go higher up into the subaxial spine. Here we only have to go 2 above, 2 below, which is plenty of fixation. You can see the medial angulation and the size of the rods and the screws, much bigger than you would typically see in the cervical spine. Here's the implant sizes. The screw lengths, the screw diameters are bigger. They're 3.8 to 4.6. And the screw lengths go from 22 to 34, so they're much longer screw diameters and lengths. Here's another case that's a C1, C2 that is a 74-year-old. This is an interesting case because the patient initially presented complaining of neck pain and had a CT scan. And this is the CT scan 3 days before she fell. You can see the cystic changes at the odontoid. 3 days later, she falls and suffers a type 2 odontoid fracture. A very difficult fracture to treat with a brace or a halo because of the subluxation and because of the cystic changes in the gap here. Also makes it difficult or almost impossible to do an anterior odontoid screw. So this is a patient who is elderly and needs C1, C2 fixation. And so we do this also percutaneously. Here we put the fiducial, the reference frame on the actual 3-point Mayfield. The stab incisions, which are lateral, here the C1 screws, here the C2 screws. You can see the percutaneous placement. Here's the final dermabond. Again, this patient went home the following day with no collar on. Here's the cervical, here's the CT scan that was done post-spin, and you can see the rods are not in yet, but you can see the trajectory and the accuracy that we have of the screws. Here's the final construct with the rods in. You can see the planning there. And then here's how the patient looks intraoperatively. This is 1 month post-op, and this is 3 months post-op. And all the surgeons, I think, recognize the morbidity that we usually see with a midline incision. You don't see any of that with that muscle sparing approach. Here's the final x-rays at 6 months. And here's the final CT scan at 6 months, and it shows the bone graft that has grown. A lot of people say, how do you put bone graft in? You're able, before you put the rods in, to use a little extra small BMP or some off-label or some bone graft material. Here we did not use BMP, we just used bone graft, allograft, and you can see on the CT scan that there is bone growth evident. And then the last case, well, I think I have one more case. This is a neuro, and so you say, well, that's great for patients who are quadriplegic. What about patients who are neurologically intact and you have to work around the cord? This is a younger gentleman, 44-year-old, also involved in a trauma. He underwent a staged anterior posterior. Here's his unilateral facet, jumped facet, and you can see the jump over here. So you say, well, unilateral jump facet, you don't need to deal with that necessarily surgically, but the patient has a extremely bad radiculopathy, and the MRI shows disruption of the disc space and all this ligamentous disruption. And even though this is a unilateral jump facet and a neurologically intact patient, this is a very unstable injury in my mind with both anterior and posterior disruption. So the patient undergoes anterior fixation. You can see after the anterior fixation, the facet has gone from being jumped to perched. And then the patient undergoes posterior fixation. You can see the reference frame placed on the spinous process. You can see the placement of the pedicle screws and the proximity to the vertebral artery as well as the spinal canal. Here is the final CT scan, and you can see that the perched facets have been reduced, and that was able to be reduced through those lateral incisions. So you're able to do some decompression. It is limited, admittedly, but here are the screws. And then here's the final fixation. This is a minimally invasive anterior with just an ACDF and a minimally invasive posterior. This patient also went home on postoperative day number 1 without a collar. And then here's another case of an equally unstable spine, an ankylosed spine. And this is a single stage surgery, and you can see the fracture dislocation. This is, although the signal changes here, the patient has an incomplete injury, but terribly unstable with the ankylosed spine and the ligamentous injury. Here's the fixation. Instead of going up to C2 and down to T2, you're able to do 2 above, 2 below, like we talked about. You can see the reference frame here. You can see the fixation. And again, you can see the screws as they traverse the pedicle. Here's the reconstructed image on the O-arm. Here's the final incision for that patient. You can see the size of the rods, and the diameter and size of the screws are much bigger than you typically would see, and that allows you to only go 1 above, 1 below. Here's his final fixation. Here he is at 3 months. Here he is at 6 months. And again, this is typically an incision that would go from there to there. And we all know, we all see the atrophy that usually accompanies that. So the bottom line is that MIS posterior there are some challenges. The decompression can be technically challenging and is limited. And this is what Oscar talked about earlier in his facet talk is that it's ideal when you're backing up ACDF or corpectomy or doing 360 procedures or failed fusion procedures or trauma procedures where the decompression is done anteriorly. There is relatively limited space for bone grafting. Like I said, it is not uncommon for us to use an extra small BMP off-label posteriorly. And then the navigation accuracy, obviously this is totally dependent on your navigation and its accuracy, so you have to have a navigation system. But in conclusion, this is biomechanically robust fixation. It is especially applicable to the aging population where you're looking to get better fixation, and you're also looking to not have the same wound morbidity. The lack of paraspinous muscle disruption is remarkable. The wound healing issues and the aesthetics are potentially game-changing. They're ideal for trauma cases, C1, C2 instability, as well as subaxial trauma, as well as anterior posterior, like Oscar talked about earlier. And with further advances of MIS posterior cervical techniques, including decompression techniques, I think this is the start of really something that will really progress with both decompression and stabilization. Thank you for having me. I appreciate the time. And if anyone is available, we're for next month in Las Vegas, we're full steam ahead with the joint section on AANS CNS joint section on spine and peripheral nerves. And the Spine Summit, this is a full go. It's going to be a live meeting, and appreciate everybody's time. Thank you.
Thank you, Dom. It was wonderful, awesome presentation, and thank you so much for the wonderful cases that you showed. And I'm no doubt there's much to do on this issue, on this topic, and this will be a major asset for us. So next, I move to Ali Baj. Thank you, Ali, for being so patient. We need to adapt here. So Ali is Chief of Spine Surgery, Associate Professor of Neurological and Orthopedic Surgery, University of Arizona College of Medicine. Eli is known for being an excellent communicator. It's always learn a lot from him. Please, Ali, talk us about enabling technologies on MIS spine surgery. Thank you.
Thank you so much. Thank you and good morning, everyone. Apologies for the delay. Thank you, Professor Oscar and Nasser, for this kind invitation. Excellent program as usual. Learned a lot, and it's really a pleasure to be here and see so many participants being engaged in these discussions. So I'm going to talk about enabling technologies with regards to CT-guided navigation. I will say, of course, as everyone knows, I would say the most recent or the most kind of innovative technologies nowadays, as you probably heard earlier in the day from some of my colleagues, robotics, augmented reality, virtual reality. But the reality is those are cutting edge, new, expensive technologies. And certainly in many places around the world, there are barely any of these innovations, never mind these very expensive ones. So I still think CT-guided navigation has a major role in spine surgery and minimally invasive spine surgery, and it will for a long time. Just if for no other reason, at least for the cost effectiveness and the and honestly the expenses associated with some of the other technologies. And that's why I want to spend some time on this topic. Here are my disclosures, none of which are related to this talk, although I will be presenting some of the tools and techniques that I use, but I'm not necessarily marketing them. Many companies and many vendors have similar technologies. So here are some of the key points in how CT-guided navigation and enabling technology has worked in my practice and for my patients, specifically with less invasive techniques and a faster transformation towards minimally invasive spine surgeries. Number one, and honestly, probably one of the biggest and most important changes is that the K-wires are out, right? I mean, I think many of you and many of the colleagues here who use any type of CT guided navigation or robotics or whatnot, you really either are not using K-wires or you're finding ways to not use them very quickly. I think that probably is single-handedly one of the best things to happen, is to avoid the potential complications with K-wires. And there are several systems out there now that allow for either open surgery, percutaneous, or especially percutaneous surgery without any wires. One-step streamlined screw insertion with these types of devices in which there's an awl, there's a screw, there's a tap, all in one. I think those are very, very efficient. And again, the highlight of this talk is intraoperative CTs. If not for navigation, then at least for checking the hardware before you leave the OR. There is, and believe me, I mean, I'm 10 years into practice, right? Certainly many more senior colleagues here and more experienced colleagues than I am. But I actually, trained using fluoro, then freehand technique, and now almost virtually everything I do is with navigation. I would say there's not a better feeling than leaving the OR and knowing where your implants are, where the screws and rods are, so you don't have to, be anxious for that X-ray the next day or the CT the next day. And of course, getting rid of the lead and the fluoro is something very important. Ergonomically, it's important. And there's just a lot of good reasons to not use fluoroscopy anymore when you don't have to. So again, many of you, as many of you know, I share a lot of these on, digitally and on social media. So you've seen this before, but this is literally the bottom right is how I used to do percutaneous screws. I used to have an AP fluoro, lateral fluoro, so biplanar, and ergonomically it was just very, very inefficient. And now, again, regardless of what system you use, now it's just so much more seamless. You have the screen, that you don't have lead, you don't have a C-arm around you, so it's just gotten so much better. The picture in the bottom right was from about 11 years ago, and then the last 5 to 6 years, really, we're just doing these navigated screws. And again, it's just, sorry about that. It's just a very efficient process. Yes, sometimes you have to maneuver looking at the screen, looking at the patient, but you get very facile at it, and it becomes just such a seamless process. Has vast applications, right? So, here's what I tell people. Being able to place percutaneous screws is probably one of the most important skill sets for minimally invasive spine surgery. Excellent talks on endoscopy earlier. Obviously, this is a little bit different. We're not talking about endoscopy, but if you're going to do any type of MIS fixation or fusions, being able to place perc screws safely, efficiently, with the least amount of radiation to you and the OR staff is paramount. And so the indications are diverse: trauma, deformity, infection, as I will show in a minute, and certainly your bread and butter fusions like a MIS TLIF. Now, here are some pearls that I will share that many folks here already know, of course, but positioning is important. Taping the patient down so there's less variability and less motion is very important. And I will highlight here number 5. Don't manipulate, push, pull the skin and the fascia too much, okay? I had one case when I was actually a chief resident. Thankfully, there was no bad outcome, but we got very lucky, in which I was trying to make the incision very small, and I was kind of moving and pushing the fascia each way, and the navigation was totally off. So a lot of people are, say, well, you can have disasters with navigation. Of course you can. Right? Of course you can, but there are ways to minimize that and mitigate against that. So what I've learned in this journey is, number 1, minimize the distortion, minimize the unnecessary movement of the soft tissue. Obviously know the anatomy. I always tell people this, that I believe I perform MIS and navigated cases efficiently because I did open surgery for such a long time. That actually has helped me become a better minimally invasive surgeon, if you will. But number two here is very important, and I'm going to spend a minute on it. Having a dynamic relationship with the system that you use. I can't overemphasize this. It's not just let's put a reference array and let's just look at the screen and let's go. You're going to have complications that way. You have to have, it's like a harmonious dance, if you will, between you and the technology that you're using. So it's giving you feedback, but you're also confirming and testing that feedback. So when I do percutaneous screws and I make that small incision in the skin and the fascia, I put my finger and I make sure I feel that TP or that facet. When I take that all in one screw and I put it on the facet and I look at that screen, I better be on the bone there and I better be feeling bone tactile, right? But if that screen is telling me, oh, you're perfect, you're right on the facet or on the TP, but tactile wise, I feel like I'm in space or I'm on soft tissue, there's something wrong. So you have to have that dynamic feedback. When I do a TLIF, when I do the decompression, I reach the corridor and I reach the disc space. I take that probe that, I use BrainLab, but whichever system you use, you take that probe, you put it on the disc space, and you better see that it matches with the screen. So it's feedback that goes both ways. And I really strongly recommend surgeons to do that more often, have a dynamic relationship with the navigation system or the technology. The techniques are going to evolve. I loved one of the speakers earlier, how he was saying that he used to do a lot of open surgery, then he did less invasive surgery, and now he's doing basically endoscopy. And that's great. I think, these techniques are going to evolve in our hands. What we do today will not be what we do 5 years and 10 years from now. There's no question about it. So the percutaneous techniques has evolved, placing retractors has evolved. And everyone is going to have their own journey in that. I post these pictures a lot. I like to share my experience with others, and this is my current iteration of how I do, for example, the MIS TLIF. I've gone away from the tubular TLIF to more a mini open approach. I like the visualization. I like pedicle-based retractors, PBRs. I like those a lot. And for me, I've just found, I just did a case yesterday, actually. I found that it's just, this is what works for me now. I know, and I hope, and I'm sure that in a few years, I will be lucky enough to adopt technology and techniques that are even less invasive than this. But again, a lot of diverse applications. So trauma, tumors, infection, the bottom right, the right screen here, the right aspect of the screen shows me and one of my excellent partners doing a lumbopelvic fixation for tumors, all MIS. And again, I used to do these with fluoro and they were fine, but this is just, the CT guided navigation is so much slicker and so much just ergonomically better in the OR. The bottom left screen is percutaneous fixation for tumors. So tumors, infection, degenerative disease, there are really wide applications for CT-guided navigation. This is a very recent case from just a few days ago, a patient with a ventral epidural abscess, where probably a few years ago, I would have done what I used to know how to do, which is do an open incision, 2 above, 2 below, fixation, wide decompression. And we really pushed the envelope a little bit here, where we used a tubular transpedicular approach with percutaneous screw fixation. So enabling technologies can make surgery quicker, more efficient, safer, but it really opens up options for you as a surgeon and for patients. It allows you to do more creative surgery and honestly, in a lot of ways, safer surgery and less morbid surgery. So that's why I like enabling technologies, and again, in these cases, CT-guided navigation, because it's a skill set that opens up options for you that you otherwise don't have. And here the intraoperative picture. This was a ventral epidural abscess. Again, transpedicular approach through the tube, mid-thoracic spine, and because of the pathologic fractures, I decided to instrument. But, this is a navigated case, but the concept is knowing the thoracic anatomy, knowing that you need it to be lateral, posterolateral approach, knowing that you can't just do a midline laminectomy. So nothing replaces a strong foundational knowledge of anatomy, technique, that you have to have that in order for enabling technologies to work for you. Otherwise, they will 100% work against you. So it's a combination of both. So in conclusions, we all know that ET is here to stay, right? Enabling technology is here to stay. It's just going to get fancier and better. You have to find a way to make it work for you, not against you. And again, for the open surgeons or the traditional open surgeons, I mean, I'm just like a lot of colleagues here, I'll be the first to tell you that for the ones that are used to open surgery, freehand screws, open things up, actually these less invasive techniques and these enabling technologies will work better in your hands because you know the anatomy and you're used to being, very efficient. It does take time. There's an upstream investment, right? The first, my first MIS TLIF took 8 hours. Now it takes 2 hours. You have to put in that time to understand and know your workflow, the OR, people to get used to it, but it pays dividends later. So it's all about putting in the time and putting in that investment. And again, it really does open up less invasive and creative techniques to deal with pathologies. I was just thinking the other day, the disease doesn't change. Infections don't change. Spondylosis doesn't change. Listhesis doesn't change. What changes is our understanding of the biomechanics of it. And what changes is our techniques to treat it in a less morbid, less invasive way. And that's what's really exciting about this is, you have the same problem and we're kind of just going around and trying to see how we can best deal with it. So again, just my thoughts on CT guided navigation and how it's still, even in the era of robotics and AR and VR, 90% of the world, 95% of the world is not going to have robotics anytime soon. Hopefully they will, but it's not there yet. CT guided navigation still plays a big role, I think, and is certainly more prolific now than some of the newer techniques. So thank you very much. Here's my email. I see a lot of participants asking for contact information and contact emails. Thank you very much again, Professor Oscar and Nasser for the very kind invitation.
Thank you, Ali.
Thank you so much. Always very, very personal, wise, and valid overview of the topic. So I think we need to go to the last speaker, and I hope Professor Pimenta solved the
legal. Yeah, I will see now. Okay. If I can share here.
Can you please share your screen?
Let's see if I can do this right now. Can you see the screen?
Yes.
I will see if I can move my slides now, right? Okay.
So Luis Pimenta is a neurosurgeon from Brazil, dedicated, one of the pioneers of the lateral approach. He works also as an association with San Diego University of California. He was a World Spinal Column Society ex-president. And as I said, he was the inventor of the lateral approach, and he's an innovator in MIS surgery. And now he comes with a very, very challenging concept, which is to perform on prone position the lateral approach to the spine. So we are very eager to listen to you, Luis.
Okay, Oscar, thank you for the nice invitation. Sorry to, I feel so old that I have difficulties with technologies, and I can do things in surgery that I cannot do with my phone or my computer. Anyway, what happened is that 3 years ago we start thinking why in the lateral, because lateral surgery was basically widely accepted in the world by different companies. All the companies, they have a different lateral techniques and cages, screws, etc. But in essence, only 20% of surgeons adopt lateral. Can you see what my screens are? Can you see my screens? No, right?
Yes, we can see a PTP value proposition.
Yeah, but they are
Only that?
miniaturized, very miniaturized.
Yeah.
Can you make it
So
bigger?
let me see how I advance this. I know how to advance my double. Mhm.
Okay, you're on your phone.
I am in my phone.
Can you flip your phone in a horizontal position?
That's
Yeah.
okay. Can you see now the next one? No.
Yep.
Yeah.
Okay.
Okay, we got just giving a lecture. You are
So
eloquent enough to
yeah, so I hope I can transmit a little bit of what is
course you
really
will.
new. So when we analyzed the problems in lateral, we saw that the reason that only 20% people don't apply lateral to their armamentary is because, it's not a very familiar positioning, placing the patient in lateral. And when you have to do posterior work, you have to flip the patient. So it's a little bit, and one very important thing is that in lateral, the sagittal alignment was not ideal. So we also found that other companies start talking about single position in lateral, which I never accept this well, because you want to adjust everything else to the lateral, and then you want to do posterior work has proven that is very limited. So basically, can you see this slide here, Oscar? The position of the patient in a Jackson table and holding the patient by thoracic and the pelvis is the key thing for this procedure, because we are working now with a patient in prone and preparing discectomies, preparing end plates, etc. So we need to immobilize the patient. Second thing is that these bolsters that hold the patient in prone, they have to articulate in coronal, such as they can open space for L4-5. So this is basically the procedure. You can do the procedure sitting or standing and raising the table to your height. But what allows this to do simultaneous procedure. You see in the pictures, surgeon doing the lateral and assistants start preparing the TLIF procedure at the same time, basically. So saves times, but not. So I think that one thing that we found is that in the prone position, the psoas migrates posterior, brings the plexus more posterior, and makes the procedure safer. So we are far from the plexus. This is another slide showing that the coronal movement breaking bringing the pelvis away from 4-5 is more efficient than in previous life that we had to break the table. So it's really very efficient, the coronal bending in the table. But important is that lateral procedure is a less invasive procedure that allows better result. And the literature is full of publications of that. So here is a case that the level that we would work was adjacent level. When we position the patient in prone, opens up, and we can do better job gaining more lordosis level by level. So this is a case. Can you see this slide?
Yes.
So this is a adjacent level spongy that in prone opens and gain a lot of lordosis by the position itself. So we were able to do 20-degree cages in those levels without taking the ALL. So with this technique, we don't do ACRs anymore. So it's very efficient, it's more powerful for gaining lordosis. Also, because of these positioners, we can realign the pedicles. You see pre-op on the left, pre-rotation the left, and in the right, the correction with the boosters. And this is basically the boosters. It's a carbon fiber adjustment in the Jackson table that, as you see on the right slides, do corneal movement and allow the surgeon to go in L4-5. We also learned that we had to construct a better retractor. So the retractor we have now is a single piece, 2-blade retractor with the marks for orthogonality. And you can see on the right slide, we target the midline. We don't go too posterior, too close to the plexus anymore. We target more anterior. We open the blades anterior or posterior. Frequently in L4-5, I target slightly more anterior, open my anterior blade, fix with the intradiscal shim, and open posterior. So we have much less risk on the plexus with this. But the last one part of the procedure that really matters is the new neuromonitoring that we have, that beside having an EMG for identification of where the plexus is, more important is to understand the health of the femoral nerve while we do the procedure. So we have SSEPs built in, and so we don't count the time inside the psoas muscle anymore. So in several cases, we can see that the SSEP waves comes down, we close retractor, wait 2-3 minutes, reopen the retractor to continue. And this has been a very important asset to prevent neurological complications, as Geronimo well told here. Here, I have 2 cases just to show examples. A spongy 4-5, I don't know if the image is good, but this is what happens. The spongy, frequently 70% of the cases, they open with a prone position. And you can see my first dilator comes much more anterior. Then I fix this, I open the retractor posterior and anterior, and you can see how comfortable is the position to do the case here. And by having the 2-blade retractors fixed, it's very stable, very strongly stable, and we can implant the titanium, porous titanium cages, the one we have been using in these procedures. And then you have the patient in the same position for your screw fixation, the posterior screw. And we can start with the posterior and then do lateral. So it's very versatile technique having this in prone. Another case here, it's a spondy. You can see the case here, a grade 1 isthmic spondy. And we start from posterior in this case, realign the spine from posterior, and then we implanted the cage. And you see that the lordosis built by position is amazing. And we have around 3,000 cases done with PTP, with posterior prone position, and we don't have cases of ACR anymore. Or in other words, means that the segmental lordosis built in this technique is amazing, is much better than before in lateral. So this is in essence what I had to present to you.
Thank you, Luis. So you
Sorry about my
you managed
my
to do
limitation.
something I never did, which is presenting from my mobile phone. Congratulations. Now, this was an awesome presentation. So now we are open to questions from faculty, from the participants for the last set of speakers.
Oscar, I can see that two of our colleagues raising hands, and they are allowed to talk. If anyone is available, please speak.
Luis, can you unshare your screen, please?
Unshare, yeah. Let me see. Stop.
Yeah.
Okay.
Perfect.
Sorry about that, Oscar.
No. So, Geronimo, can you ask some? I would like to see a Brazilian fight here.
Almost impossible.
To Professor about this turning the patient. I'm convinced. I have to say, it's what I like is inserting the screws first and reduce the elasticity, for example, for those cases, and makes the life easier.
Yeah, there's no reason for a fight. Congratulations, Dr. Pimenta, once again.
Thank you.
What I want to ask you is about what is the main difference in terms of the tools you were using, because for doing the lateral approach, we can use any kind of implant, but it seems to me that the most important difference that you are using right now is the table. I know that the Jackson tables are not so available. We don't have one here. We have one Brazilian adaptation of the model. But it seems to me that the table makes a great difference in this kind of surgery. Can you tell a little bit about this? Thank you.
Yeah, so no doubt that the table has to be to allow to accommodate the lordosis of the patient and not have pressure on the belly. So even I know some Brazilians adaptations of the Jackson table, if we have the rails, we always can mount the bolsters and hold the patient if the table is doesn't have a block for the belly. Because then you hold, the key thing in this procedure is to make the patient immobile and based on a bolster in the thoracic under the axilla, and the second one in the pelvis on the femoral, about the femoral position. So, and these bolsters allow coronal movement, and by the coronal movement we can go to 4-5 easier. The key thing in this procedure, in my opinion, the main advantage still is a lateral procedure, has the same advantage, but because the patient is in prone, gains natural lordosis. Second, the plexus is more posterior, and third, we arrive in the disc much more in the front, so we are away from the plexus. And the last one is that once I open my retractor anterior and posterior, I follow the SSCPs, which is the key difference between in previous life that we would open the retractor and count minutes. That was not very scientific. I think we have several advantages in this procedure. The adoption in this procedure in US has been very, very fast, much easier than, as you probably know, adoption, positioning the patient, the time consuming in breaking the table correctly. So we don't have this anymore. and the possibility to do lateral posterior or first posterior, take the previous screws, do your lateral, place new screws. So it's a real procedure, posterior and anterior at the same time, basically.
Luis, just a very quick question, very technical question. But when you do a lateral and you break the table, sometimes if you have a high iliac crest, this can be a useful maneuver. Since you can do that on prone, how do you solve cases where the iliac crest is a little bit higher, hiding, reaches
No, thank you. This question is critical. So other companies are trying to do prone lateral, and what they see as a limitation is exactly that, L4-5. How you fix this? So what we found is that we need a positioner holds the pelvis very strongly and coronal rotate the pelvis. So this positioner replace the breaking the table. It's actually more efficient, gains 25 degrees of coronal rotation. So the only impossible L4-5 high crest are the one that are transitional levels. Those cases we cannot do lateral, and the reason is because it's not a real 4-5, is a kind of a 5-1 level, right? The vessels are there. It's not only the nerve that is more anterior.
Excellent, thank you. Dom, I have a question for you, Dom.
Sure.
I really appreciate your cases, and C1, C2 was a little bit scary. Where did you fix your fiducials in this case? Because C1, C2 is really mobile. Even when you do it open, you can see it moves all the time, right?
Yeah, that's the trick. That's one of the tricks. And for C1, C2, it's tough because you can't really put the reference frame on the actual spine. If you put it on the spine and the spine moves, as long as it's moving together, you're usually okay. And that's the trick with C1, C2. You have to put it on the frame, typically speaking, and putting on the frame's not moving and the spine potentially is. And so you have to be careful not to be leaning on the patient. And some of the other speakers talked about some of the technique, but it's even more critical. And then when you're going cortical bone to cortical bone, you have to be careful not to be pushing too much. And if you feel like things have changed, you have a very low threshold to respin if you need to. But it is something that if you do that, you can maintain your accuracy. You just have to continue to check your accuracy. The problem with navigation isn't when you're way off because you can tell something's not right. It's when you're just 2 or 3 millimeters off because that puts you in a canal or in the vertebral artery. And that's one of the things. But yeah, you have to when you make your incision, people talk about some of the excellent, pearls of how to deal with navigation. Don't struggle with fascial incisions. Don't push your instrumentation. You have to go smoothly. Use, taps. Use bigger taps if you need to, etc. But you have to do all that stuff in order to minimize the movement of the body.
Great.
It's a great question, Oscar.
Nasser, I don't see any good questions here in the
Okay,
so
okay.
I think we need
anybody would like to say any comments or any questions among the panels?
I'd just like to say thank you for putting together a great job, both of you. A fantastic job. I've been involved with a lot, and this was a great meeting. Thank you.
Thank you very much. Gupta, do you like to say something? Do you have any comments? Introduce yourself and start, please, before we close.
I'm Dr. Uday Gupta. I'm a neurosurgeon in India, sir. I want to ask, sir, when we're doing a fusion, how many levels of fusion will you call a safe fusion? Like going above 2 levels of fusion, fusing 3 levels, 4 levels, that will cause, more breakthrough. What is the safest, how many levels can we safely fuse?
Is that
Okay.
directed to anybody in specific?
Whom do you like to ask, Gupta?
I mean, in general, to anybody, like in degenerative spine, when we are going for a long segment fusion, how many like 2-level fusion is the safest, or 3-level? Should we avoid multi-level fusions? How to go do that?
Geronimo, do you want to give an answer, please?
Well, it's strongly dependent on what you need to fuse. I mean, if you're going to have a degenerative imbalance, maybe you need a lot of levels to be fused. The point is what kind of correction you need. But for a lateral approach, we can do from L2, L3 to L4, L5. In some cases, we can do L1, L2 as well. But in these cases, when there is either coronal or sagittal imbalance, you always will need a posterior stabilization together with the anterior support. Dr. Pimenta has a lot of experience with that. And there are some cases where we can do safely standing alone, either ALIF or lateral. But if there is a deformity, I'm pretty sure that we need to fix from posterior as well.
Michael,
Yeah.
do you like to say something?
Who?
Michael, do you like to say any comment?
So if I can add a little bit on that, is Pimenta here. I think that the number of fusion levels depends on the pathology, of course. We can, especially when we do lateral, we can fuse anterior and or posterior. I really learned through these 20 years of experience in lateral procedures that the best lateral procedure requires a posterior supplementation. So standalone, especially now that we have the patient in prone, doesn't make sense anymore. It takes another 20 minutes to place percutaneous pedicle screws. So we typically do 3 levels in the same position for mild degenerative scoliosis. Very rarely we do more than that, but we can do as many levels as needed.
Thank you, Luis.
Thank you. Oscar, do you like to say any closing remarks before I close the webinar?
We are now approaching 3 hours.
Okay.
So I really like to thank all the faculty. They were really awesome. These are top level speakers in their field. Also, a word of appreciation for the participants that we had. And Nasser, it was really a pleasure to work with you, and I'm sure we can repeat the dose.
Thank you, Oscar. It was a great collaboration. It was a great webinar. My apology that we extended the webinar for about 4.5 hours, but actually all the presentations were excellent. Discussion was very interesting. At the end of this webinar, I'd like to thank Oscar for this opportunity, to thank all our distinguished speakers. May I not forget to thank organizing team, Dr. Hassan Ala and Ahmed Magdi, for the great job they are doing in organizing this series of webinars. Thanks to all participants. Remind you, next activity, 11 February at our usual time. It's going to be a WFNS Educational Symposium with Professor Luis Borba about traumatic brain injury. Thank you very much for everything, and see you later.
Thank you very much. Bye-bye.
Thank you very much. Bye. Bye.
Thank you. Goodbye.
Ah, não é isso, é o contrário. Que os livros. Desligado.